and they're going to be able to see it later if you want. And you're going to be able to share the link of the YouTube recording with your colleagues and with your team. So please, if you find this meeting interesting, share the link with everybody. And follow us on social media so you can get to know our next activities. And please participate on the Q&A chat box. So all of your questions during this webinar, please type on the Q&A, and all the faculty is going to be super happy to try to answer as many questions as possible during the webinar and use some of them on the discussion in the middle and in the end of this session. If you are a Spanish speaker, please join us on this very interesting webinar about CCTGA that is going to be on the 4th of December and is going to be in Spanish. On next Monday, we are going to have the second part of the BTT Shunt 76th anniversary. We made a very nice part 1 to celebrate this anniversary. If you missed it, please go to our YouTube channel and watch it because it was really amazing, including we listened the experience of one actual patient who is now on his 70s, and he was one of the first patients that had the BT shunt in history. So it was a very, very interesting story to listen from him. So go to your YouTube channel, catch up with this last meeting, and please join us next Monday. And then on the 8th of December, Gil Vernovsky is continuing his series. And on this one, it's going to be very special because he invited some friends. And we are going to talk about interesting topics, including women in pediatric cardiology, leadership, teamwork, training, and all of that. Please join us. This is going to be very special. And on the 14th of December, we have the imaging series of Dr. Norman Silverman. He's going to talk about anomalous pulmonary venous connections, and he makes a very nice correlation between the echo imaging and the morphology. It's really worth watching. On the 17th, we are going to have an update on fetal cardiology. Please register for that. And every Friday, we have Dr. Anderson talking about morphology of the various anomalies of heart disease. So please join us every Friday. He's going to continue the series until 2021 as well. Now, Melissa is going to say a few words about the next PCICS meeting. Melissa.
Thank you, Grace. So we are really excited at PCICS for our 16th annual meeting. Of course, this year it will be a virtual meeting. We have some exciting sessions that are related to neurodevelopment in partnership with our a collaborative society at Congenital Cardiac Anesthesia Society. One exciting thing about this meeting is that there are tiered registrations. So if folks are interested to check out the website, we have various registration options depending on your country of origin. We're really excited. There's several networking opportunities. We're going to talk, we're going to have a session about diversity and inclusion. So please be sure to join us, and we look forward to seeing you at PCICS next week.
It's going to be amazing. Thank you, Melissa.
Thanks, Grace.
And now today, during this webinar, guys, we are going to have a very interactive session. So if you can please scan this QR code on your phone, or if you want to type this website address on another window of your browser, we are going to be able to participate in the pool, on the audience pool, and we are going to have a very nice and interactive session. Gil is going to talk more about this soon. Okay, so now we are going to start. This is going to be a very interesting meeting. Thank you for all the speakers, and thank for all of you to join us. Gil.
Thanks, Grace, and thanks, Sasha, and thanks everyone for attending today. This is, I think, our 78th or 79th free webinar since the pandemic began. We've reached about 125 countries, I believe. The attendees would probably never get a chance to travel to an international meeting. So I do want to thank my colleagues on the faculty for sharing their expertise all around the world. And I think what's also quite unique about this particular webinar is it's the first time, I think, that we have a combination of long-term outcomes feeding back on short-term care. And the whole purpose of this is we've learned what happens to kids as they grow up, and we're going to talk a little bit about that. But we have to figure out what's modifiable years ahead of that to improve the outcome for where we go. So I do want to thank the members of the Pediatric Cardiac Intensive Care Society as well as the Cardiac Neurodevelopmental Outcomes Collaborative. And I'd like to introduce the moderators for the next 2.5 hours, 2 hours or so. First is Andrew Van Bergen. Andrew's a very good friend and wonderful singer in the Baby Blue Sound Collective. If you want to check that out, he's a pediatric cardiologist at Advocate Children's in Oak Lawn. He's the director of their CICU and also the director of their neurodevelopmental program at Advocate. So obviously he's got all the skills for what we're going to be talking about today. His interests are in interdisciplinary care, of course, for patients with complex heart disease throughout the spectrum of life, especially for complex disease like HLHS, but also in the management of critically ill kids with heart disease, ventilation strategies, et cetera. His clinical interests focus on outcomes research, both within the ICU and cardiac neurodevelopmental fields, dealing with both novel ventilation strategies, hospital safety, and improvement endeavors. And he's an active principal investigator on numerous industry-sponsored trials. Also, another dear friend I've known for many, many years since we worked together way back at CHOP is Andrea Torzone, who's the clinical nurse specialist in the cardiac intensive care unit at Children's Medical Center in Dallas. She's been doing this position for over 20 years for cardiac patients. She focuses on education and quality improvement. She is the co-lead for the inpatient neurodevelopmental team at Children's in Dallas with the Red Balloon, and a member of the Cardiac Newborn Neuroprotective Network, CNNN, don't confuse that with CNN, which is a special interest group of Pcics-Cnoc-Cha. So I'd like to turn this over to Andrew and Andrew.
Thank you very much, and good morning, good afternoon to everyone in attendance today. I want to thank the organizing committee within the Congenital Heart Academy, especially Grace, Sasha, and Gil. On behalf of Andrea and myself, we are very pleased to help moderate today's sessions. I'm going to start by introducing our first speakers, including a topic on the scope of the issue at hand, neurodevelopmental outcomes in congenital heart disease, historical context, paradigm shift. I'm pleased to introduce our previous speaker and announcer, Dr. Gil Warnowski. He is a senior consultant currently in pediatric cardiology and cardiac critical care at Children's National Hospital in Washington, D.C., United States of America. He is founding member of the Pediatric Cardiac Intensive Care Society, the Cardiac Neurodevelopmental Outcome Collaborative, the International Society for Pediatric Mechanical Support, Circulatory Support, and the World Society for Pediatric and Congenital Cardiac Surgery. Along with Jeff Jacobs, he is the co-chair of the 2023 World Congress of Pediatric Cardiology and Cardiac Surgery.
Dr. Warnowski will be co-presenting with Erica Sood. Dr. Sood is a pediatric psychologist in the Nemours Cardiac Center at Alfred I. DuPont Hospital for Children in Delaware, and associate professor of pediatrics at Thomas Jefferson University. She's the immediate past chair of the Pcics-Cnoc-Cha and directs the Cardiac Learning and Early Development or LEAD program at Nemours. Her research focuses on neurodevelopmental outcomes, inpatient developmental care, and family psychosocial interventions for congenital heart disease.
I'm going to start out. What we had tried to set out through this webinar is to start out with our current state of knowledge, the scope of the problem. At the end, my colleague Melissa Jones at Children's National is going to tie together how individual centers can do this. And in between, there's going to be a series of very rapid, I guess I call them quick hitters. Each one of those topics could be a symposium or certainly a 3-hour webinar in and of themselves. So we're not going to be able to get through all of it, but we hope that this piques everybody's interest in why anyone who works in an intensive care unit or in the operating room, anesthesia, bedside staff, social work, everyone has a role in improving long-term outcomes. And I hope that we can prove that and show you that all today. So I want to start out just to give you a rough idea of what Eric and I are going to talk about. I want to try to put what we're talking about today to what some of the younger generation may think is something we've always understood. Describe the scope of the problem, and Erica is going to talk about the long-term follow-up and what we've seen. And then we're going to talk, of course, over mitigating brain injury in the CICU and your role in all of this, as I just discussed. We had a fantastic webinar yesterday on tetralogy of Fallot, wherein it was actually the early 1940s where the first Pcics-Cnoc-Cha shunt occurred. And the 44th patient who ever had this done described his journey. He had his tetralogy repair at 21 years of age. It's an amazing interview, and I would recommend you log on to the YouTube channel to see that. But this was the point where we first realized that it could be done. And Seawalt Lillehei up in Minnesota, great place. The two largest cardiac surgical centers in the world at that time were 90 miles apart in Minnesota. And this is where intracardiac repair got its start in the mid-50s. Intensive care units only got, the first PICU, for example, is 1969. On your right is a crash cart from those days. And the old style bird ventilators are shown there in the early 70s. It was about the mid-80s, and I know in Boston about 84 is when, 83, 84 is when the first dedicated cardiac intensive care unit came to be. Cindy Hogan is in the middle picture, late Cindy Hogan. She's one of the nurses who taught me what I needed to know about cardiac intensive care. And mortality fell dramatically at that point, and we were so proud of ourselves that we now had babies that were growing into adults. And we thought that that was pretty much it. The dogma at the time was that the only thing wrong with these kids was their heart. And we were like, high five me. But the elephant in the room didn't get back to the intensive care unit or to the surgeons, but was seen in the outpatient department years later. And one of the first papers talking about this in the modern era of cardiac surgery was Peggy Ferry's about neurologic sequelae of open heart surgery in children. And at the time, we thought this was all the surgery. And again, that would be a topic for a whole nother session. But open heart surgery, although there can be disasters that occur in there, plays a quite minor role in how these babies do over the long run. But we had our head in the sand. I was trying to talk about the First World Congress of Pediatric Cardiology and Cardiac Surgery. This was our view. At the time, in many places, neurologists were not even allowed in the cardiac intensive care unit for fear they would scare the patients or blame the surgeons. And fortunately, all that has changed because we needed to decide at some point who owned this problem. Those of us that worked in an inpatient arena or operating room arena didn't see these patients, and the people who saw these patients over the long run were not skilled to take care of and diagnose and manage their neurodevelopmental problems, deal with their school forms, things like that. Two of my colleagues and great mentors and friends are Jane Newberger and David Bellinger. And in my view, they're the two people that took ownership of this problem and was the first collaboration between a pediatric cardiologist and a pediatric psychologist. And along with others in the Boston Circulatory Arrest Study, started following these kids and coming up with a game plan. The patients from that study are now in their young 30s, believe it or not, and there's still about a 65% retention rate, and they're all being studied right now, the majority of whom are parents themselves. So if we take that now as a starting point, we started initially to describe how the kids look. We were investigating the risk factors for adverse outcomes and understanding some of the mechanisms for brain injury in our patients and the beginnings of understanding the role of parental, specifically maternal mental health and adjustment. The next step, where we are about now, is treatment. And some things are really exciting in the fetal world, in the intraoperative world, and in the outpatient world. And that's where we are today. And that's why we're having this webinar about 30 years later. To put some of this in perspective, it's been 24 years since the PCICS officially formed, and we had our first meeting in Florida. And it's been about 10 years since CNOC formed. So what we're going to try to do then is go from the fetus with congenital heart disease through an incredibly stressful to every system course in the cardiac intensive care unit to that first visit where the babies look absolutely fine except for the sternotomy in the outpatient department. And what I'll say to everyone in here, what you do here on the left has a lifelong impact over the long run. And we all need to take ownership now of what this means over the long run. The CICU for a long period of time was this black box, that there was what happened when the baby was born, maybe we'll measure cross clamp time, something happened, and then we saw these kids in the outpatient department. But we're realizing now that it's not just a black box. There's a number of things that we're going to talk about today that can mitigate the problems, eliminate the problems, and improve long-term neurodevelopment. So I'm going to set for this conference what has been called a BHAG, or a big, hairy, audacious goal, and that our job over the next 5 to 10 years is to eliminate secondary brain injury in the cardiac intensive care unit. So that's why we're here. How big is this problem? And for that, I'm going to turn it over to my colleague, Erica Sood from Nemours.
Thank you. So as written by you, Gil, in Cardiology in the Young, the combined outcomes of developmental delay, academic difficulties, and behavioral abnormalities represent the single most common morbidity affecting quality of life for survivors with congenital heart disease. And as a pediatric psychologist who works with patients with congenital heart disease from infancy through young adulthood, I wanted to review some of the key findings that we see in this patient population through the developmental stages. So in infancy, we tend to see high rates of neurobehavioral impairments, similar to what you see in the CICU or the step-down unit. These kids tend to be more irritable. They have a harder time with self-regulation. They exhibit feeding delays, even after hospital discharge. And they have high rates of gross motor delays, so difficulties with head control, tolerating tummy time, rolling, sitting, crawling. As children progress into later infancy and toddlerhood, we see high rates of speech delay and language delay. Children have difficulties with fine motor skills, so using their fingers and their hands to complete tasks. And we see greater rates of sleep difficulties and sleep regulation. As children progress into toddlerhood and school age, we tend to see social deficits. So children with congenital heart disease are diagnosed with autism at higher rates, and even children who don't meet criteria for autism sometimes have difficulties with social cognition. We see higher rates of behavior problems. As children enter into school, more children are diagnosed with ADHD. They exhibit executive functioning difficulties, so difficulties with planning, organization, working memory. They may have difficulties with learning, so reading, math, and visual motor deficits, so difficulties with handwriting, drawing, visual spatial tasks. And through later adolescence and the transition to adulthood, deficits in adaptive skills can cause difficulties with that successful transition to independence. We see rates of social deficits. Kids just don't tend to be as mature as we would expect for their age. Higher rates of anxiety and depression, and all of that can lead to underemployment and poorer quality of life. Next slide.
Hold on one sec, Eric, I'll get it.
Okay.
There you go.
So as over the last decade, as we've seen these challenges and the struggles that families have and patients have around these challenges, individual centers began developing cardiac neurodevelopmental follow-up programs. And the goal of these programs is to identify these challenges as early as possible to make referrals to developmental services and supports such as school services, early intervention services, to provide families with anticipatory guidance. So we hear from families, particularly families of kids, older kids, that they felt blindsided. They had no idea that this was going to be really a lifelong challenge for their child or now adult, and felt that they thought that their child was fixed, right? They weren't going to have these types of lifelong challenges. We also provide family support. So family support around, how do you advocate for your child in the school setting? How do you manage all of the therapy appointments and everything that your child requires, as well as support around emotional coping, both for the patient as well as the family. Next slide. So there are now, I would say about 50 programs, maybe more, cardiac developmental follow-up programs at individual centers. About 8 years ago, these centers came together and really formed a field of cardiac neurodevelopment. I think in 2012, at a meeting in Boston, is when many of us would say that this really expanded to a field. And in 2016, CNOC, the Cardiac Neurodevelopmental Outcome Collaborative, was officially formed. So it was in the works for about 8 years, but the official formation of CNOC was actually 2016. So we're not actually that old. And we are a multi-center, multinational, multidisciplinary, inclusive group of healthcare professionals committed to working together and partnering with families, so we have parents and patients involved, to optimize neurodevelopmental outcomes for individuals with congenital heart disease through clinical, quality, and research initiatives to maximize quality of life across the lifespan. Next slide. And our mission is to determine and implement best practices of ND services for every individual for congenital heart disease and their families through clinical, quality improvement, and research initiatives. Next slide. So we are, CNOC is led by a large steering committee. We now have close to 45 centers, primarily in North America, although we are expanding to Europe, and we're looking to expand worldwide. So if anybody on this webinar is interested in getting involved, please reach out. We have, like I said, patients and parents on our steering committee, and also on all of our standing committees. Next slide. We are a founding member of Cardiac Networks United, so we work with other collaboratives to improve care and outcomes for patients with congenital heart disease. Next slide. And we launched our clinical registry in 2019 as a module of PC4 and PAC3. So the obvious benefits of this are that the long-term neurodevelopmental psychosocial quality of life data can be linked with data from the CICU and the step-down unit to be able to identify early opportunities for change. We have 25 sites entering data to date, others that are in the process of contracting. Over 1,600 assessments have been entered to date. And we are in the process of conducting the first set of analyses. And there's opportunities for investigators to lead projects as well using the CNOC data. Next slide. We have 8 standing committees that support CNOC operations, as well as member-led special interest groups. So this is an opportunity for members to get together, form a special interest group around a shared interest. The steering committee has approved 3 so far, all that have been proposed. The Cardiac Neuroprotective Newborn Network, which we'll be hearing from a lot today, diversity and inclusion, and congenital heart disease and the developing brain. So again, I encourage anyone on this webinar who's interested in CNOC or wants to get involved, regardless of whether your center is a member, please reach out. You can reach out to me, you can reach out to Gil, or really many of the presenters on here, and we can give you more information.
Thanks, Erica. Looks like that's it. I also wanted to mention to the audience that we're very excited about this. One of the things that we've been working on for, I think, 3 years now, Erica, has been standardized guidelines for assessment. And we've, a week or 2 ago, published the guidelines for 0 to 5, which includes a basic core as well as an expanded core, and then also guidelines for long-term assessments from age 6 to 18. And I'll put those links in the chat box at some point during this session. Are we going to the poll now? Is that correct? Andrew, is that, I think that's next on the list. Is that correct?
That is correct.
All right, I'll just continue to go from here. I'm going to need to share my screen. So Grace showed you this QR code earlier. I would ask you to scan that or enter into your second browser, ahaslides.com/PCICS-CNOC, all capitals.
On the chat box, guys, just click on the link. You can get this open on another browser. Just click on that.
Oh, good. And as you can see in the bottom right-hand corner, we have, what, about 170 people online right now? I can't see it on my screen. So it'd be really...
227.
I'm sorry, how much?
227 watching.
227, awesome. So let's hope that we can get at least half of you to log on to get a representative sample. No stuffing of the ballot box. You can only answer once. And the goal behind this is for us to learn at the Congenital Heart Academy who's been logging in, how we can do a better job, and then also to do a little bit of a pre-test to get an idea of the audience's baseline understanding of where we are in this field. And I want to thank my fellow faculty members for sending in these slides. So let's do the first one here. Again, just to get used to the system, are you a member of the PCICS? The link is right up there, and I'll put a plug in for the PCICS annual meeting, which happens next Wednesday to Friday. There is a free annual membership to Tier 3 and Tier 4 countries, which is a great opportunity to get involved in the society and get an idea of what that would look like. And we'll put that link again in the chat box. Very good. So for the 52% of you, we will send you information. What about Pcics-Cnoc-Cha? How many of you are involved in this? And I probably should have added a I don't know in here. And we're dealing probably with about the same ratio, right? About half of the people in the audience would like to learn more about Pcics-Cnoc-Cha. Pcics-Cnoc-Cha just had its annual meeting. It was fantastic. It was virtual like all of these. Real kudos to the organizing committee for Pcics-Cnoc-Cha. Tell us, it's hard when we do these Zoom meetings, like you have no idea who you're looking at in the audience. So if you don't mind checking just really quickly, what's your gender? And that's most of the people. And then finally, your age. Paul, I'm sorry we didn't have your age on here. Oh no, I'm sorry, we can go over 80. I apologize. This curve, Sasha and Grace, this looks like just about every webinar that we do, that the sort of plurality are in the 30s to 40s. And you are the younger generation that's going to take this field to a whole nother level. It's very exciting. How'd you learn about the webinar? I'm going to just leave this one on quickly. You check as many as you'd like. Okay. These questions will stay open. I'm going to go through them fast so we have time for all of our speakers. What best defines your practice? Excellent. All right. The SLTs, OTs, PTs, please share this with your network so they can see this on the YouTube channel. And lots of others. I'm hopefully can figure out what those others are. I suspect we have a number of patients and parents on as well. Where do you live? Wow, Asia, it must be midnight. So thank you for joining us. And this is pretty much the distribution in the Pcics-Cnoc-Cha member organizations, it looks to me like, Erica, so not too surprising. Hopefully we can spread that word. All right, a couple of pre-questions. What percentage of children with VSD that are repaired with heart failure in infancy, they don't have a syndrome, have measurable neurodevelopmental and psychosocial disabilities, the so-called straightforward VSD? No syndrome. So we can take our patients with Down syndrome or CHARGE or any of that stuff. And again, there's not a lot of grouped data here, but we will have it with Pcics-Cnoc-Cha soon. But most of the papers, in fact, do say it's somewhere between 10 to 30%. What about with tetralogy? Again, no DeGeorge, no syndrome, elective tetralogy repair in the probably the first 6 months of life, I would say. So the group's doing well with the correct answer by 60 of you, 60 of the 110. All right, we're getting a little more complicated now. What percentage of children with HLHS and single ventricle have neurodevelopmental or psychosocial delays? Group's doing really terrific. It's somewhere, most studies will suggest it's somewhere between 50, between a half and 2/3, but it's certainly not all of them. And sometimes we say that's the case, but we have to remember that although as a group they don't perform as well, there are many individual patients who are completely normal in every respect neurodevelopmentally. And what about transposition? Blue for a while, then pink. Oh, we were close. Whoops, that didn't come out. I'm sorry. The correct answer here is roughly 2/3. And we haven't really gotten better since the original Boston circulatory arrest study. So there's a lot more to it than the diagnosis, as you can see. All right, last few, based on a few things. Do newborns with CHD need a video swallow evaluation to rule out aspiration before they can start oral feedings? And Jennifer's going to talk with us about this. I believe she's our next speaker or the speaker after that. So roughly 18% of us, or 20% of us, a little less, think they should have a video swallow. A feeding therapist should only be consulted when the newborn with CHD is ready to orally feed with a bottle or at the breast. Oh, this is reassuring. Jennifer, I'm curious if you find any of this surprising, but we'll get to that as we get to the talk. Newborns with CHD have difficulty with feeding due to neurological differences caused by their congenital heart defect. All right, so we're hanging around half and half, 2/3, 1/3. Does your institution have sternal precautions? Chris Carringer talked about this, including restriction of prone positioning following cardiac surgery. Now, some of you may have already seen the title of the talk called The Myth of Sternal Precaution, so you may be a little bit biased there. But so 2/3 of the institutions roughly have restriction of prone positionings and sternal precautions. Should awake prone positioning be restricted in infants following hospitalization for cardiac surgery? So after discharge, for how long? I remember the early dogma from years back was in the pink bar. So it'll be interesting to see how this has changed, why this has changed, and what is thought by the experts who are going to be talking with us today. The most common reason given for sternal precaution. We didn't put on here because the surgeon told me to, although I guess that's physician preference. And maybe David, you'll comment on that in the discussion at the end. Lower gross motor scores have been significantly associated with, and I think this is a check all that apply. I'm not sure, but the green bar wins. Which, if any, and this may be small to read, but which, if any, of the following developmental care practices have been implemented or are available within your cardiac ICU? And this does have check all that apply. Wow, what a change from 5 to 10 years ago. This is fantastic. This is great. I hope some of the team, and Melissa, I know you're wrapping things up at the end. It'll be, it's really quite reassuring to see at least the people that decided to come into the webinar, which is a little bit of selection bias, but that we're doing a lot more than we used to. Justin sent these questions in. Which, if any, neurologic monitoring practices are utilized in your CICU? And I don't mean for a conduit change in a 12-year-old, for the at-risk patient, which by the AHA scientific statement guidelines are neonates and young infants who have surgery on cardiopulmonary bypass, those with cardiac arrest, and those with ECMO. All right. I know Dan Licht is on. Dan, maybe when you come in, you can talk a little bit about what we've learned from this, what's worth the effort. NEARS has certainly caught on, but interestingly, only 35 of the 83 respondents say that we use routine cerebral NEARS. Now, maybe a lot of the respondents don't work in the cardiac ICU. The subsystems of infant behavior, just a couple more to go. The subsystems of infant behavior include the autonomic system, the motor system, the state organization system, and the self-regulatory system. And this was Sam Butler's question. Thank you, Sam. Well, it looks like we have a pretty standard answer here. Developmental care is A, modifying environment and caregiving to meet an infant's expectation, care of infants to maximize neurodevelopmental outcome, the care for stable infants, and is care only for preterm infants. And it looks like, again, we have a predominant answer. All right, I'm going to turn this back over to, that was fun. Thanks everybody for participating. I'm going to turn this back over to Andrew and Andrea.
Thanks, Gil. Those questions are a really great setup for this next panel. And when I saw the program for this webinar, I was really genuinely excited, because anyone who's involved in trying to improve and promote neurodevelopmental care in their cardiac ICU or in their heart center knows that this is not a one-person initiative at all, or a one specialty initiative. And we're learning that more and more. And this kind of rapid fire section really includes many of the disciplines that are integral for making a successful neurodevelopmental program. So nursing, physical therapy, cardiology, psychology, neurology, speech therapy. We have a really great collection of experts today talking about how that individual role in the cardiac ICU can influence long-term outcomes for our fragile patient population. So we're going to lead it off with a good friend of mine, Jill Zender, talking about 24/7, 365, the role of the bedside nurse in promoting neurodevelopment. So Jill has held several roles in the cardiac ICU in her career, starting as a bedside nurse for 8 years. And most recently, she's been a nurse practitioner for the last 4. Right now, she is at Texas Children's Hospital, where she's an active participant in their developmental care team, as well as a member of the developmental care workshop team that works to increase neurodevelopmental education opportunities for all of the staff in their heart center. So I'm going to hand it off to Jill to talk about the very important role of the bedside nurse.
Thank you so much, Andrea. I'm really excited to talk about this. This whole webinar is a mesh of both of my 2 favorite things in life, PCICS and developmental outcomes. So I'm really excited, and thank you all for the invitation. Can you see my slides okay, Andrea? Okay. So as we all have an idea of, I'm sure, nurses have a million different decisions to make at the bedside daily when they care for patients. The sicker the patient, the more decisions they have to make, and nearly every single one of these decisions impacts neurodevelopmental outcomes in some way. My overall goal with this talk is to just give a quick overview to really equip bedside nurses with the knowledge that they need to make the best decisions to optimize neurodevelopmental outcomes, and to really give the rest of the partners on the care team an idea of the balance required to take care of these critically ill patients 24 hours a day, 7 days a week, 365 days a year, to provide excellent intensive care to these critically ill patients while also making decisions that will lead to optimal neurodevelopmental outcomes. I have no disclosures, but I should mention, as Andrea mentioned as well, that I am no longer a bedside nurse, which makes me really excited to take the opportunity to talk up the role of the nurse. I don't think the importance of a bedside nurse can be overstated, so I'm excited to talk about this. So as we all know, surgical outcomes have improved so much over the years. Even in my 12 years in the cardiac ICU, outcomes have changed dramatically. So survival is really no longer our goal. Really, even graduation from the ICU should no longer be the goal. That's the exception and the expectation, sorry. We really need to shift our focus and work on implementing developmentally appropriate care and making this care as excellent as the care we provide in the ICU. It can be challenging to consider that ICU experiences in infancy impact neurodevelopmental outcomes and who these infants become as children and then adults, but there's obviously abundant research that supports this is the case. As a bedside nurse, we have unique opportunities to be the patient's neurodevelopmental specialist 24 hours a day, 7 days a week, by not only incorporating small practice changes, even in the way we care for patients, but we also have the opportunity to reinforce all of the other goals and cares that the rest of the care team provides to also increase these neurodevelopmental outcomes. As Gil mentioned earlier, a lot of the risk factors that these patients are faced with are not modifiable. So we really have to work to improve the risk factors that we can modify to improve the outcome for these children. There are a few key opportunities that bedside nurses have to implement changes into their care to include developmentally appropriate care daily. I'm just going to briefly touch on these. As Gil also mentioned earlier, I could probably do an entire webinar alone on the bedside nurse's impact on developmental care. But everything that I talk about is going to be reinforced, and I'll give the how in this talk, but the speakers later in the webinar will really talk about the why. So making small changes by including the family in the patient's care and focusing on family-centered care, focusing on optimizing the environment. Positioning is a huge thing to increase and improve developmental outcomes for these patients. And then sedation, which is also, again, most of these patients are immediately post-op, and pain sedation is a huge topic. So we'll briefly discuss all of those. So the first is family-centered care. It's important to include the family as a whole when caring for these babies, but this doesn't necessarily mean family-driven care and having the family decide all of the decisions at the bedside or making decisions just because it's the family, what the family wants, but really focusing on making decisions with the family in mind, encouraging them to participate in decision-making when appropriate, and then facilitating their participation in the patient's plan of care. The ICU is incredibly intimidating for, it can be intimidating for the staff sometimes, so it's even more intimidating when it's a parent's child laying in the bed. A lot of times they're covered with lines, tubes, wires, or they're so tenuous clinically that it's hard for the parents to feel that they are able or feel comfortable interacting with their child. So we really need to focus on helping parents understand on a daily basis how important it is to interact with their child and give them appropriate recommendations for how they can interact with their child. Every day is going to be different, and maybe today they can only hold their hand, and then a week from now they can change their diaper. So it's important for them to understand daily how they're able to participate. Another way to really help with this is to have the parents help create a daily schedule for the patient, have a wake up time. All of our patients have their various therapies, so have them kind of occur all at the same time. And then have the parents incorporate things that are important to them, like nap time, choosing a nap time that works for them at home as well. Bath time, a lot of parents really appreciate participating in bath, and it helps them feel bonded and connected. So try to pick a time with the parents that these things work for them as well. Not only does this help them, again, bond, but it also kind of gives them something to look forward to. They're forward thinking and planning when the baby will no longer be in the ICU, when the baby will be at home, which can decrease a lot of stress to help them know that this will end someday and they have something else to look forward to. And then, as I kind of briefly mentioned already, it's important to create opportunities to help promote bonding. Time in the ICU is frequently time lost for parents to bond with their infant with conventional methods, holding, feeding. There's a lot of fear and anxiety associated with the hardware that each child has. And sometimes the patient's clinical condition can even preclude the parents from holding. In these instances, really in all instances, I would recommend this care partnership pyramid, which was published by Janie Klug and colleagues, and Dr. Sood as well, who spoke to us earlier. It's really a helpful visual for parents to know exactly what they can do with their child and when, and there's different suggestions in each category. So starting from the top of the pyramid, working down, the top is when they're most critically ill, they're immediately post-op or immediate post an event or something like that. So by participating in rounds, asking questions, having them bring items from home, holding their hand, all the way down to once they're more stable, getting ready to go to the floor, getting ready to go home, they can participate in all the care, practicing what PT, OT, speech has taught them, providing really all of their care. So it's helpful to have this visual in the room and have some sort of indicator, like a magnet or circling it or something, to help the parents know exactly where their child is on the pyramid and exactly how they can participate in their care. Another way we can optimize outcomes as a bedside nurse is small changes in optimizing the environment. The biggest thing, and I think probably the most important thing, is facilitating appropriate day-night cycling when able. So using cycled lighting to mimic day and night. When they're immediately post-op, we have the lights blasting all day, all night. But as soon as they're more stable, and when we're more able to do so, really focusing on using natural daylight if possible. I know not everybody has that ability, but using the lighting to really optimize when day is day and night is night, and dimming the lights for nap. And if you do have to turn the lights on, just doing the small things to make sure you're protecting their eyes when it's shining in their face and stuff like that. There's a lot that we can't avoid. And of course we have to be able to see, but just really thinking about how that's impacting the infant. Encouraging the parents to talk to the babies as they would at home. I talk to my babies all the time as if they were my friends and just normal people. And I think that because of the stress of the ICU environment and the critical nature of the child, I think that there's a lot of anxiety about parents making too much noise or bothering the child. So when it's appropriate, make sure you're encouraging the parents to talk with the infants. And again, not only helps with bonding, but also helps with their speech and language development right from the start. And then finally, kind of a juxtaposition to that, also ensuring appropriate volume. Make sure there's not excessive noise of television or music in the room. I know a lot of hospitals have what we call the care channel, which plays the calming music all the time. And a lot of times I walk in the room and it's full blast. It's really not necessary to play that all day and all night anyway. I think it's maybe more calming to us than it is to the infant as it is. But if you are going to use the noise machines or the television for the music, make sure it's just at a very low volume and really just background noise. And another thing, we all come to work, we're excited to see our friends, especially now that we can't socialize with anyone really ever. It's really our only outlet for socialization. But just be mindful of the conversations that you're having inside and outside of the room to help keep the environment conducive to healing for the infant. Positioning is a huge thing and is really a game changer. A well-positioned, comfortable infant is a much happier infant on all fronts. Not only does it help with just overall comfort, but appropriate positioning and containment can also help with pain control, which can reduce the amount of opioid or sedative exposure that the infant will receive, which again will impact neurodevelopmental outcomes in itself. You want to ensure that the head, neck, and hips are all in neutral alignment. A lot of times our babies come back from the OR and the frog legs, arms outstretched position is pretty common, and necessary, honestly, sometimes to be able to have a full view of the infant. But as soon as you can, if you can just make sure the baby is midline and their arms and legs are flexed as much as possible, it is really a better position for the infant in the long term. This is a hard one. Allow hands to mouth when appropriate, and consider this even if the patient is intubated. We can secure an ET tube pretty well that a tiny infant is likely not going to be able to pull it out on its own. Of course, this requires supervision, and I wouldn't just let that happen and leave the room. But when infants can put their hands to their mouth, it's a much more calming position than restricting them from doing that. So even if it's for short periods at a time, just consider allowing the infant to bring their hands midline and to their face. And again, swaddling is a lot of times the best position, but ensure that their hips are flexed and they're not, positioned down and stuck in the downward position. All of this decreases the amount of stress experienced by the infant, which impacts neurodevelopment long-term. It also helps with development of their motor skills. And then finally, pain and sedation. This is a really tough one. A lot of our patients are, like I said, immediately post-op, and pain control is a priority on top of the many other sources of pain that they experience: an ET tube, dressing changes, pokes, NG placement, even care as basic as a diaper change can sometimes be painful. We know that sedation medications and opioids have a negative impact on neurodevelopmental outcomes, but we also know that uncontrolled pain and stress also negatively impacts outcomes. So there's really not a right or wrong answer for this. I'm really just asking you to consider non-pharmacologic methods of pain control first. Of course, I'm not talking immediate post-sternotomy, but a couple hours or days out, consider things such as swaddling, containment. If you just put your hand on the infant's head and apply pressure at their feet or legs, that can go a long way and maybe not completely avoid the infant's exposure to narcotics and benzos, but can definitely dramatically decrease the exposure. So it's just a consideration, but again, not the ultimate answer. So I went through all of that kind of quick, but my overall message is that bedside nurses have such an important role in shaping the neurodevelopmental outcomes of patients. They're one of the most consistent providers on the team. They're with the infant constantly, and it really makes a huge difference in who these patients become in the long run. The first conference I ever attended was my first year of nursing, and I really probably had no business attending the conference because I had no idea what they were talking about in most of the sessions. But one of the sessions I went to was a developmental care session and focused a lot on positioning. And that, I remember it like it was yesterday. It stuck with me even 12 years later to understand the impact that we truly have at the bedside. And it's also important to consider that if this is not something that you already do in your practice changes take time and patience. But even if you just take one thing from something that I said today and try to implement it today and increase this care in your practice, it'll make a huge difference over time. So, thank you so much for letting me talk.
Thank you, Jill. That leads really nicely into our next presentation, which is critically important and a big hot topic right now: positioning and the myth of sternal precautions. I think there's a lot of, we do this because we've always done this. So hopefully Chris and Karen will help shed some light on that. So our speakers are Dr. Karen Uzark, who's been a nurse practitioner for more than 40 years, caring for children with congenital heart disease or those undergoing heart transplantation. She's also an outcomes researcher in the Congenital Heart Center at the University of Michigan, with a special interest in quality of life, including neurodevelopmental outcomes. And her co-presenter is Chris Tapley, who's been a pediatric physical therapist for 19 years. His primary focus for the last 15 has been working with children with cardiopulmonary disorders in the acute care setting. And he currently serves as the occupational and physical therapy supervisor for the Pcics-Cnoc-Cha Children's Hospital. So please take it away, Karen and Chris.
Thank you. Well, my goal in this session is to dispel the myth of sternal precautions, and then Chris will describe the tremendous potential of positioning once that myth is dispelled. Next, we have no disclosures. It's really very little published about sternal precautions, but fortunately, less than 2 months ago, believe it or not, a study was published, a nationwide survey on sternal precautions and prone positioning of infants following median sternotomy. A web-based survey with 21 questions completed by 68 participants well represented by professions throughout the United States, cardiologists, advanced registered nurse practitioners, nurses, therapists. And they found, next slide please, that approximately 80% of the participants reported having institutional protocols for pediatric external precautions. The duration varied from 1 to 2 weeks to 7 to 8 weeks, with 5 to 6 weeks being most common. More than half of the participants reported that their institutions had prone positioning restrictions as a component of the external precautions. So fairly similar to what we heard in our survey this morning. The concerns for limiting prone positioning due to the sternotomy included incision healing, most frequently, fears of sternal separation, and the surgeon or institutional preference. Next slide. But they concluded there was a lack of empirical evidence to support sternal precautions or prone positioning restrictions. Next slide. Well, since most often when I ask the nurses why their sternal precautions or why they don't put the babies in prone, it's because the surgeon won't let us. So we have a quote here from Jennifer Romano, one of our pediatric cardiovascular surgeons, who couldn't be more supportive of developmental care. And she said, "What I tell all of my parents about sternal stability and what they can do with their baby after surgery is, if I did my job right, you cannot break them." And not only have we found no evidence to support sternal precautions or restricting prone positioning, we have found some data to show that it can be safely performed even in critically ill infants. And a paper even that's found that prone positioning was safe in ECMO patients and did not increase the risk of complications. Next slide. So we wanted to look at that more, and we did a study a few years ago looking at infant motor skills after a cardiac operation, just to get a sense of, what was going on. Most of the research had been done in infants following discharge and longer in their clinical care. We found that motor impairments in hospitalized infants for cardiac operations were common, and that motor skills declined postoperatively, which you might expect. Importantly, I think we found that lower gross motor scores pre-discharge following cardiac surgery were significantly associated with longer duration of mechanical ventilation, just greater than 2 days, and ICU length of stay greater than 5 days. Of note, as the manuscript reviewers requested, we explored and found no significant association between motor skills and STAT, surgical complexity category. So it seemed to be related to the environment, the postoperative environment, which was, of course, involved prolonged periods of immobility, supine positioning, confinement after the operation, which all impede motor development, may contribute to loss of motor strength and previously acquired skills and delayed developmental progress. So we found a need for developmental. Next slide. So where's the evidence of prone positioning? We found a great deal of evidence that said that awake prone positioning is positively associated with improved gross motor development, as well as other developmental outcomes, decrease in the incidence of plagiocephaly. So these are just a few of the papers, including a systematic review paper. And the last paper there by Wentz looked at the importance of initiating tummy time in infants with Down syndrome and found that it was very important to initiate tummy time in the first 11 weeks of life, certainly an age range that we see in our patient population, as well as seeing patients with Down syndrome. The next slide. So we decided we needed to do a study looking at awake prone positioning or tummy time in our postoperative cardiac surgery patient. Evaluate tummy time intervention to skills in infants after cardiac surgery. And we'll be submitting it for publication this month, but the results are in, and it was a very positive association. Next slide.
Okay. So I'm going to kind of take it from here and talk a little bit about what we have done at Mott Children's Hospital and what our experience to date has been. In 2018, we developed a developmental care clinical practice guideline and initiated that. This was the result of a multidisciplinary effort by staff representing various disciplines and roles within our health system. The goals were to improve neurodevelopmental outcomes in infants with congenital heart disease, standardize practice to include multidisciplinary implementation of developmental interventions, and periodic neurodevelopmental evaluation. One key aspect that we found with this, or that we decided on with this clinical practice guideline, was the elimination of sternal and prone precautions. We'd been moving towards this as an institution, but this standardized it and eliminated all of our precautions. As part of the developmental care clinical practice guideline, guidelines were developed similar to what Jill had touched on in her presentation for environment, infant positioning and handling, feeding and oromotor skills, therapies, comfort and pain management, and post-discharge neurodevelopmental surveillance, evaluation, and intervention services, excuse me. The other thing that we did was we did initiate developmental rounds during that time, and we've touched on those a little bit briefly, but these multidisciplinary rounds are done bedside on a weekly basis. Patients birth to 3 months that have spent greater than 5 days in the ICU are currently included in these rounds. The guidelines defined in the clinical practice guidelines are addressed and how they relate specifically to each individual patient. So we go over with the families and with the staff involved, how do we touch on each of these areas and how does it affect this particular patient and what do we need to do better? What are we doing well? What's working? We found this education to be a vital part of our developmental care efforts. The other component that we did is we have developed an infant positioning and handling visual aids. These tools were developed for use during rounds for both positioning of intubated and non-intubated infants. These help to encourage appropriate use of positioning aids and allow further family and staff encouragement. This one here on this slide is a portion of our prone positioning guidelines for our 0 to 3 month population. It provides pictures with appropriate positioning, as well as a prompt for the position to be completed at least 2 times per day. Here are the full posters for both intubated and extubated patients in our 0 to 3 month population. Coordinated early mobility and positioning is encouraged as often as possible, depending on clinical status. Along with prone positioning, sitting, supine, side and sideline positions are encouraged throughout the day as the child condition allows. And during rounds or during our therapy sessions, these positions are demonstrated to families. Staff work to ensure families are comfortable with placing their children in these positions as appropriate and encourage regular interaction. The appropriate posters are hung at bedside throughout the patient's admissions for further education and encouragement. Finally, a little bit on kind of what we have seen so far. Since we've started this initiative, and as I said, it started in 2018, but had been in development for several years prior to that, was formalized. But since changing with no sternal precautions, we've seen no increased incidence of sternal complications, despite that lifting of all those precautions. Our parents, we are finding, are much more comfortable with playing with, handling, and engaging with their children, as shown by many of these pictures. These are all pictures taken while our children were in the hospital, often in therapy, but many of these just interacting with their families or during developmental rounds. We've also heard from families and providers that this continues at home, and we've seen it on subsequent admissions. We are seeing improved developmental positioning and play by all staff, so not just with our families, but all of our nursing staff is becoming much more comfortable. Our physician and nurse practitioners are much more comfortable talking about this, encouraging this, and also an early involvement with our therapy services when needed. And most importantly, our patients are given the best start for a long-term developmental outcome and success. Thank you for letting us present today.
Thank you, Karen and Chris. That's really fantastic work. Congratulations. I'm excited to talk about that more in the panel at the end. So we're going to keep this moving and move on to Dr. Justin Elhoff, who is an intensivist at Texas Children's Hospital and assistant professor of pediatrics at Baylor College of Medicine. And at Texas Children's, he has been leading the efforts to form their multidisciplinary inpatient developmental care team. And some of his clinical interests focus on how the practices, systems, and environments created within the ICU really influence the developmental trajectory of patients, as well as their long-term outcomes for patients and their families. He has multiple other clinical champion positions for Pcics-Cnoc-Cha and PC4 and Pcics. So Dr. Elhoff is going to talk to us about the 30,000-foot view, how the cardiac intensivist can promote positive long-term outcomes.
All right, thank you guys so much for joining today. Can everybody hear now? All right.
Slides look great.
Well, thank you for joining, and I'm definitely honored to be able to discuss the intensivist perspective on what we can do to really take ownership of what I think many of us here believe is one of the most pressing issues in congenital heart disease today, which is the long-term outcome, specifically of our patients born with critical heart disease. I have no disclosures. And I think that it's fair to say that almost all of us who are drawn to the cardiac ICU really love the real-time physiology that we experience on a daily basis. And in some maybe a little bit twisted way, we actually thrive on the volatile, uncertain, and often complex environment of the CICU and become pretty comfortable with making critical decisions and seeing the results of those decisions in the time frame of minutes to hours. Certainly, growth and experience within the perioperative care of patients with CHD is an important factor contributing to the improved survival that we've seen over the past several decades. But as we heard in the introduction, we're realizing the incredible prevalence of long-term neurobehavioral challenges that are often the most significant morbidity for many of our patients. And given what we know about this lifelong burden of neurodevelopmental impairment, I would argue that focusing solely on shepherding our patients through their period of critical illness isn't good enough for us anymore. And in order to provide truly excellent cardiac critical care moving forward, we must understand and implement some practices, systems, and environments in order to optimize the developmental trajectory of our patients. So if we watch this NASA created image viewing, kind of zooming out from Houston, Texas, let's consider what we can do as cardiac intensivists who are often accustomed to fast-paced decision-making with rapid feedback on our results to kind of take that 30,000-foot view, getting away from our microenvironment of the ICU in order to focus on how we can influence the lifelong outcomes for our patients and their families. So using this image that I think is familiar to almost all of us who work in a CICU, I want to walk through two broad aspects of which we in cardiac intensivists can take some ownership and are compelled to act to optimize the long-term trajectory of our patients. So I think of these two arms as comprising something called developmentally savvy CICU care, which is really just a paradigm that emphasizes the long-term outcomes for our most fragile patients. The first component is our traditional role in excellent neurocardiac critical care. And the second component is this intervention of developmental care, which I know Dr. Butler is going to delve into more deeply in a few minutes. And so I want to discuss a few ideas within each of these domains by which we may promote excellent long-term outcomes. So let me start with some of our aspects that are more in our wheelhouse often as cardiac intensivists. And that is also, if we start with what we have the strongest evidence for, and that is the fact that generally speaking, spending time with us is not good for our patients. And of course, intuitively, this makes sense because there are certainly cardiac and extracardiac factors that are associated with prolonged ICU stay that will also increase the risk for worse neurodevelopmental outcomes. But the fact remains that in study after study, even when we adjust for surgical, patient, and socioeconomic factors, we see a strong correlation between time in the ICU and worse neurodevelopmental outcomes. And while we can't necessarily snap our fingers and reduce ICU length of stay, the first step in providing developmentally savvy care means thoughtfully moving our patients through our system as efficiently as possible. And so to me, this idea is epitomized by a quote from UCLA, great, UCLA basketball coach John Wooden, that said, "Be quick, but don't hurry." And while every patient inevitably has unique characteristics that need to be taken into consideration, if we can utilize consistent, principle-driven practices to guide the de-escalation of care as clinical benchmarks are met, or kind of alternatively, taking a step back and reassessing what we might be missing when there are delays in expected progression, can help us facilitate moving patients along while not putting them at undue risk. And whether this is utilizing something like the flight plan concept or target-based care measures, once we understand the expected course, it can really help us utilize our expertise in the ICU in order to know when we can step on the gas versus when we might need to pump the brakes a little bit. And if we kind of step back and take that 30,000 foot view, as Karen was just talking about, when we move our patients more efficiently through the ICU, we're removing noxious stimuli, we reduce the opportunities for iatrogenesis, and we can decrease barriers to provision of optimal developmental care. So as we're focusing on efficiently moving patients through our CICU environment, the next question becomes really understanding what factors make time in the CICU so deleterious to long-term outcomes. And this gets to Gil's kind of BHAG that he was talking about at the beginning, that was to eliminate secondary brain injury in the CICU. And I wish at this point that we could tell you that we have a plethora of robust data-driven evidence regarding these relationships between ICU practices and neurodevelopmental outcomes. But at this point, in a lot of ways, these relationships remain a black box. We certainly have a fair bit of physiologic plausibility, as some of the tenets of excellent cardiac critical care, such as optimization of oxygen delivery and prevention of cardiac arrest, are intuitively beneficial for the developing brain. And increasingly, we're gaining signals such as small studies exhibiting correlations between cerebral nears and neurodevelopmental outcomes, or growing evidence regarding topics such as postoperative brain injury or the association between sedative agents and delirium with poor neurodevelopmental outcomes. But at this stage, I would still argue that we have a relatively immature understanding of so many of our practices and the role that they play in our patients' long-term outcomes. We don't have robust studies or even unified approaches, and as we saw in our initial poll questions, towards things like postoperative neuromonitoring, sedation protocols, or the interaction between nutritional status and longer term outcomes. And with this in mind, I think that the second action I would implore us as cardiac intensivists is that we need to occasionally at least take this step back and zoom out from solely focusing on the acute results of our practices, but both insist upon and ourselves perform, when able, research that utilizes outcome measures that will help us to gain a better understanding of the relationship between our practices in the CICU and neurodevelopmental outcomes, both in the short and long term. And so shifting gears a little bit to something that hasn't necessarily always been as much of our focus as in cardiac intensivists, that's this idea of the intervention of developmental care. And I would really strongly like to make the stance that this is not something that we do that's kind of cute or nice when it's convenient for us, but a culture that we strive to promote every day because we think it's vital to maximizing the long-term outcome for the patients in our care. And returning again to this picture, I think this idea of developmental care to me kind of simplistically encompasses, one, remembering that there is actually a baby at the center of all of this action going on, who is going through a critical period of development amidst everything else. And we need to be cognizant of how we're interacting with this baby at all times. And then two, what I think is most interesting to me in this picture is this drawn curtain back here, and acknowledging that what is happening on the other side of the curtain, as it were, with the family, probably has as much impact on this patient's long-term outlook as all of the medical things that we're doing right now. So again, I will leave it to Sam in the next talk to really educate us a little bit more about what developmental care in the CICU looks like. But kind of simplistically, I think the idea, a great deal of it boils down to attempting to create some form of normalization of infant routines within the wickedly abnormal environment that we have in the CICU. And at the same time, constantly empowering and engaging the family as the patient's primary caregivers. And I'll admit that these ideas are natural probably for some of my colleagues in the CICU. So what is our role? And I don't deny that while that isn't what maybe drew a lot of us to work in the CICU, as we navigate our patients safely through their potentially dangerous CICU course, I think we have to maintain that big picture focus and that ownership of how we can provide developmentally savvy care, and admit that these areas may not be our expertise per se. And so our role in this might be more as a facilitator. And with this, we need to engage with our multidisciplinary teams who we work with to understand and mitigate the barriers they encounter. And just like Magic Johnson here, make it easy for them to use their talents to serve our patients. And that would be my third major point, is that I would encourage us to establish a culture wherein we cultivate, enable, and promote the expertise of our colleagues to work their magic with our patients and their families. And then finally, returning once more to this picture, I think we really need to acknowledge the importance of what's happening on the other side of this curtain. In this actual instance, a month or two ago, there was a young mother literally huddled in the corner, just completely terrified of what was going on to her baby out here. And I hope we'll talk more about this in the panel discussion, but I think we need to recognize the extreme stress and trauma experienced by many of our patient families. And not only just how prevalent this is, but I think it's fascinating to understand that parental stress and mental health status at the time of hospital discharge from the neonatal hospitalization have been shown to be at least as predictive of our patients' long-term neurobehavioral outcomes years later when they're starting school, as all of the clinical factors that we often will measure, such as bypass strategies or postoperative complications. And I really believe that an opportunity to truly move the needle on neurodevelopmental and quality of life outcomes for our patients may be to insist upon focusing on the well-being of the entire family unit. And this entails taking a holistic approach, not only to the care we provide our patients, but the entire family. And I understand personally, it certainly can be hard when you're on service in the ICU to be appropriately busy managing everything going on in the unit, and sometimes be blissfully unaware of what's happening within the family units of our patients. But the final point I'd like to make is that going forward, I don't think that we can isolate our clinical patient outcomes from the family outcomes. And even though we may be a patient's provider for a short time in the ICU, I think it's incredibly vital and challenging time for our patients and their families as well. And we have to remember kind of our ultimate goal is to get these patients well so they can be home and cared for in an environment to maximize their long-term potential. And this is a follow-up picture, I guess it's a little bit covered here, from us conducting developmental care rounds a couple weeks later on that same patient. And while we've seen some nice clinical progression, obviously, I would hope that as a heart-centered team that we've laid the foundation not only for short-term milestones, but also setting he and his family up for long-term success. So summary, I'll cut it short here, but I'd emphasize us focusing on moving our patients efficiently through our system and insist on better understanding how our care can influence long-term outcomes and work to eliminate that secondary brain injury in the CICU. Set our multidisciplinary teams up for success, and remember to always treat the entire family unit throughout the CICU stay. So with that, I thank you and look forward to our panel discussion in a bit.
Thank you, Justin. That was actually a very nice intro also for our next topic, which is going to be led by Dr. Sam Butler. Dr. Butler is the director of the inpatient neurodevelopment in the cardiac neurodevelopmental program at Boston Children's Hospital and is an assistant professor at Harvard Medical School. She is a NIDCAP professional and co-chair of the Family Advisory Council for NIDCAP. She is also co-chair of the QI Committee of Pcics-Cnoc-Cha and vice chair of the Cardiac Newborn Neuroprotective Network called CNNN, which is a special interest group of Pcics-Cnoc-Cha. We are pleased to have Sam join us today to give us a discussion on promoting long-term outcomes using developmental care in the CICU. Welcome, Sam.
Thank you for having me today. Let me just... There we go. So I am going to talk a little bit about developmental care in the CICU. I have no disclosures or conflicts of interest. And as we already heard, we know that neurodevelopmental disability is one of the most common morbidities for individuals with CHD. And we even see this pretty early in development. Our work at Boston Children's, we follow the children soon after birth and surgery. And so this is showing you our neurodevelopmental exam for children that had surgery in the newborn period. And we're seeing just before going home. So these children were determined safe enough to go home and doing quite well in medically. But when we look at their neurodevelopment, we're seeing a lot of difficulties right in the beginning. So we see difficulties with motor tone, asymmetry, including torticollis and plagiocephaly. We see challenges with social interaction and attention, difficulties with rooting and sucking, and also difficulties with self-regulation, showing us a little bit that these children could be challenging once they're at home in terms of their behavior and needs and caregiving. We also find at that same time when we measure parent stress just before going home, they're showing a pretty high rate of depression, anxiety, and stress. But also when we look at the parent stressor scale, we can see a little bit what is or what was the most stressful during the hospitalization. So some things that we see are parents reporting that infant appearance and behavior was stressful. But also what's quite pulling is that parents report that they couldn't parent in the hospital. And that's where they were showing stress around that role change in the hospital than what they expected. And they also find the sights and the sounds in the hospital to be stressful. So where are these challenges in development coming from? So I think it's important to look back at brain development so we can understand a little bit of why we end up in this area of developmental concern. So we know that there are numerous neuronal tracts that are formed in utero and many more neuronal connections that are created than are actually necessary. And these brain connections that are not used are pruned back and die off. So connections that are used through experience are what remain. So we think of this sometimes as the use it or lose it phenomenon. So experience is actually shaping the brain. And this is where it's so exciting for us because now we have the opportunity to actually enhance development through experience rather than interfere with development through experiences. If we think about the experiences in the CICU though, we have technology, isolation, and discomfort. So we got to think about which of these neuronal tracts are actually kept while you're developing in the CICU. And we know the three promised environments, this is what the brain is expecting. These are the tracts that should be kept. Ability to be close with your family, the mother's womb, the breast and body, and the social group. But there's a mismatch between this expected environment of the brain and the actual environment in the CICU. And we think this is what leads to some of the brain developmental differences that we see in children with CHD. So what is developmental care? We often talk about it, and I think sometimes people use the words and have different definitions. So just for this talk, developmental care is when you read an infant's cues, you modify your environment and care practices to meet the brain's expectations. So knowing, or at least interpreting what the brain might be expecting, all to increase positive long-term outcomes. And one model of developmental care is NIDCAP. That's the Newborn Individualized Developmental Care and Assessment Program. And highlighted in red is the word individualized, because I think that is what's so important, is because developmental care has a lot of prescribed therapies, but it's important to be individualizing those for the patient. And NIDCAP is the only evidence-based model of developmental care. And there are a lot of studies looking at NIDCAP and showing that it improves long-term developmental outcomes in terms of medical variables like ventilator days, oxygen days, tube feeding days. It also improves long-term neurobehavioral functioning, frontal lobe engagement, and white matter development. And parents following the NIDCAP approach report more confidence and competence in their care. So along with Erica Sood, who you met earlier, we surveyed hospitals, certified CICUs in North America to look at their use of developmental care. And we found varying degrees of developmental care in the different CICUs, although many were reporting that they were ill-equipped to really carry out developmental care, and that they wanted more education and resources for developmental care. So back to looking at what is developmental care. We all know that when we're providing patient care, we do a medical assessment, we create a plan, we implement the plan, we reevaluate the plan. But the first thing we should be doing, developmental care, is doing a behavioral assessment of the patient first. So really understanding your patient, reading their behaviors, reading their cues, and changing your caregiving and the environment to follow along with the infant's brain's expectations. So behavior is continuous expression of brain function. It's always available to be observed. No matter how sick or ill the child is, you can always read their behavior. And in terms of behavioral observation, what we're really talking about is looking at the autonomic system, the motor system, so tone, posture, movement, state organization, attention and interaction, and self-regulatory. So the infant's efforts to regulate themselves, or strategies or successes to self-calm and regulate. And all of this in interaction with the environment. So you would know that an infant is doing well while you're doing a caregiving if you see good color, good respiration, well-modulated posture and tone, hands to face, foot clasping, grasping, sucking, robust sleep states, alertness. And then you can feel pretty comfortable that you're providing care that is meeting this brain's expectation. However, if you see disorganization and stress, such as respiratory irregularity, color changes, bowel movements, tremoring, extensions of arms and legs, fisting, grimacing, fussing, hiccuping, sneezing, coughing, yawning, gagging, all of these means you really need to pause, reevaluate the caregiving, reevaluate the environment, and make changes to support this infant to come to a more relaxed, calm, and organized state. So NACAP has developmental care recommendations, but the very first recommendation is always to read the infant cues. Rather than just implementing different therapies or recommendations, you first have to read the cues to determine what the brain or the infant might be expecting, to determine that child's strengths and weaknesses before moving forward. And some of the recommendations include changes to the physical environment, the bed space and bedding, and also direct caregiving. So we all know we're aiming for this calm care area so that the infant can grow in peace and quiet. But what does that really mean? So the World Health Organization has hospital noise guidelines that the room should not exceed 35 decibels. So when we look at what that actually is, that means a whisper or a library. So this is very, very quiet. And this is what we should be attempting to achieve at all times in our CICU. There's also guidelines for light levels, which should be for a newborn ICU between 10 and 600 lux. And if you look here, that is between twilight and an overcast day. So this is quite dim. And this would even be for during the day when the child is awake. In terms of direct caregiving interactions, we're really talking about moving from task-oriented to relationship-based care. So we all have tasks that we need to complete, but you should think about when you're going into a room, what are your goals? Do you have goals that you're trying to complete right now? Or is there a way you can really think of this as a relationship with the infant to get to the same end goals? And so this is where we also talk about engaging with rather than doing to an infant. And so I pose a question to everyone that we use a lot of terminology in our CICU, which imply that we're doing to the infant. And I know we all use these things like even the word positioning. To me, that sort of implies that we're doing something to the infant. We're going to move them from one position to another position, rather than really engaging with them. Or we could say something like we're supporting the infant to self-calm, to bring their hands to midline. Other words you might hear are things like do up, which really are also implying doing to the child rather than engaging with. we're all working to promote parenting, and this is what I think is so important looking at our research and what parents are reporting on the time of discharge, and that they felt like they couldn't parent. So really promoting parenting, promoting the parents as the primary caregiver, so that from the very beginning, they are engaging as much as possible with their infant, making decisions for their child, that their child can see, hear, feel, and smell the parents while they're in the unit, in terms of really promoting attachment and bonding. I also lead another question about wording that we use often, and I hear this from families, that we say things like, my child, or I have the child, my child today is in bed space, whatever. And the parents think, well, that's not your child, that's my child. And other things that is so that we might not be thinking of the parent as the primary caregiver. Even using the word empower, I've had a family tell me that the word empower implies that you have the power to give to me. Whereas if you really believe that they're the primary caregiver, that would not be the case. So it's one thing to understand developmental care. It's a very different thing to implement system-wide change. And we've heard a lot about these different types of change today already. Obviously, having a neurodevelopmental program that follows children inpatient, outpatient, providing developmental team rounding. We have a developmental care program in cardiology where we have education for staff. We have guidelines on developmental care so that people understand what we're trying to achieve at the bedside and can be held accountable. And also, I think what's very important is research and quality improvement metrics to continue to find new ways to bring developmental care to the unit. And also support and information for families from the fetal period all the way through outpatient. And so I put these up here if you wanted more information on developmental care or connecting with other individuals that are working on developmental care. So the CNN, as was mentioned before, which is the Pcics and Cnoc. You can also find more information at didcap.org. I also put my email here if anybody would like to reach out. So in summary, individualized developmental care is effective, is the right of each fragile infant and family. We know that the babies have one brain for life, so this is our opportunity and responsibility to really provide them the best behavioral and developmental care that we can. Thank you.
Thank you, Sam. Those were some really nice summaries and hints for all the people in the audience of things they can take back to their unit. Carrying along that message, we are going to go more in detail and learn more about the brain. We are pleased to have an attending pediatric neurologist of high acclaim, Dr. Dan Lick. We are pleased to have him join us today. He is the director of the Wolfson Laboratory for Clinical and Biomedical Optics at Children's Hospital of Philadelphia. Dr. Lick specializes in coma and prognosis, intensive care neurology, neurologic complications of congenital heart disease, and pediatric stroke. Dr. Lick has a special interest in the caring of children with severe congenital heart defects and their effect and how that has affected their brain development. Along with his work at CHOP, he is the Children's Hospital of Philadelphia Department of Pediatrics Distinguished Endowed Chair and Professor of Neurology and Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. In addition to his clinical role, he is a researcher whose current focus involves building and testing optical devices to measure brain oxygen metabolism, brain blood flow, and pressure inside the skull. Please welcome Dr. Licht, who is going to describe in 10 minutes what every CICU provider needs to know about the brain.
No pressure there. Thank you very, very much for that kind introduction. Can everybody see my slides and hear me?
You look great.
Perfect.
Great, Dan.
All right, thank you. So how do I advance the slides? There we are. So I have some disclosures just related to patents that I hold on optical devices, some of which will be discussed later. As an outline, just sort of an overview of the newborn brain with CHD, with congenital heart, some principles of cerebral physiology, and how we put that all together using new tools, and that will hopefully hit the CICU near you fairly soon. The first major principle is the ambivalence, the paradox between brain care and heart care, is that everything that's good for the brain is bad for the heart and vice versa. So the brain likes it wet, the heart likes it dry. The brain lives on afterload, the post-surgical heart dies on afterload. These are all problems that we face all the time. And in that, we've recognized that neurodevelopmental challenges have existed as long as we've been caring for congenital heart. Originally, surgical strategies were blamed, but that is clearly now trending away from surgical strategies and more on patient factors and care factors. A series of articles in the early 2000s really led to that. And the most important of all of those is Bill Maley's article in 2002 that showed us that there was brain injury that existed even before the surgery. And that made everything sort of veer away from surgical strategies and looking more at the child and what happens during the care in this ICU. So fetal brain development has been now the target of a lot of studies and interventions. There's no doubt now that our babies born at term with congenital heart have a premature brain. Their bodies may not be premature, but their brain certainly is. And this was sort of highlighted in this article that we published, now seems ancient history, but where we looked at maturation of infant brains and compared to normals, and found that the maturational pattern of brain MRIs in babies with congenital heart not only were delayed compared to full-term infants, but were delayed compared to infants that were late preterm, so up to 36 weeks. And so really, this showed us that the brains were basically the equivalent of a 34, 35 weeker at the time of delivery, at full-term delivery. We also showed a little bit later on that there were things that predicted the white matter injury, not just the immaturity, but things like days to surgery were starting to be clearly associated with brain injury. Here is Chris Pettit's article looking at time to surgery and oxygen, dissolved oxygen concentrations in the blood. And even if you had high oxygen concentrations, as this child here did, waiting for surgery did not save you. The oxygen set, partial pressure of oxygen did not save you from brain injury. So this, we thought at the time, was the first study to show that time to surgery was a risk factor for white matter injury, but it really wasn't. Actually, the first study looking at not white matter injury, but neurodevelopmental status after heart surgery, showed that VSD was associated with poor developmental history, but it was highly correlated with time to surgery. And so the authors of that study had to choose one of the variables, and they chose VSD. So this is the white matter injury, and this is a heat map looking at postoperative MRIs in 101 infants with congenital heart that received bypass in the first week of life. And as you can see, it's widely distributed. It is periventricular. Steve Miller has since published that it is the same position, the same topography, and the same geometry as the white matter injury that babies born prematurely get. So it is essentially the same injury. And what we see that the hottest points, the hottest parts, so where injury is occurring most commonly, is in the periatrial, so the posterior part of the lateral ventricles, and the frontal part of the lateral ventricles. And so what rides in these areas? Well, when you do functional brain MRIs, it's very easy to assign a cortical area of function. Language, we know very well where language is. We know pretty well where face recognition is. But when we look at white matter tracts, there's not typically a function that you can assign. But we do know that in these areas, the superior longitudinal fasciculus and the inferior longitudinal fasciculus, that's where those tracts reside. And we do know what those tracts confer. They're very important in transferring information from the hippocampus or memory to the visual cortex, the occipital lobe, to vision perception in the parietal lobe, and then sort of the personalization of the experience in the frontal lobe. So how do we prevent this injury? So some of the principles of brain oxygen metabolism are simply this. What is CMRO2, which is the rate of the cerebral metabolic rate of oxygen, which is the product of cerebral blood flow, the oxygen content of the blood, and the oxygen extraction of the brain tissue. Oxygen delivery is simply the product of cerebral blood flow and the oxygen content of the blood flow. But what do we have access to? Do we have access to cerebral blood flow? No. Do we have oxygen or brain extraction? No. We really only have the oxygen content. Now, can we use the tools that are in our CICUs currently to get some sense of these values? Well, NIRS the commercial NIRS that we have access to makes a lot of assumptions and generalizations based on populations, and not so much the age of the patient. It makes an estimate of cerebral oxygen saturation by a ratio, which is also an estimate, of arterial blood and venous blood. But this might not fit every child at every point in time. And so it's really not quantitative. And so it's used as a trend value, but that's not going to help you sort of understand what the metabolic rate of the child is at any given point of time. The one valuable thing is that total hemoglobin concentration, which is the sum of oxyhemoglobin and deoxyhemoglobin as measured by the NIRS instrument, does trend with cerebral blood flow volume. And so that could be used as your surrogate for cerebral blood flow if the makers of these commercial units would give you access to total hemoglobin concentration, which they don't. So going back to the cerebral metabolic rate of oxygen, what of this is modifiable? Well, really only the oxygen content, which is a constant times the hemoglobin concentration times the oxygen saturations. So maximizing content would help the brain. Do we know if there's a relationship between cerebral blood flow and mean arterial pressure? Well, we hope that there's not, because when there's not a relationship between cerebral blood flow and mean arterial pressure, that's the happy place of the brain, and that's what's called autoregulation, where small changes in mean arterial pressure result in no changes in cerebral blood flow. That blood flow is maintained by intrinsic mechanisms in the brain, so that deviations in mean arterial pressure in a normal range of mean arterial pressure keeps cerebral blood flow constant. But we can't just rely on hope, because we actually don't know where we are in this autoregulation curve. So it's not a good strategy. So we need new tools, new thinking. And one of the tools that I use is this optical instrument, which can measure quantitative cerebral oxygen saturations and can quantitate cerebral blood flow. And the mechanisms behind this are too complicated for a 10-minute talk, but using these two instruments for measuring blood flow and oxygen saturations, you can calculate metabolic rate. And this is all very nice because it can explain the physiology that we had observed 10 years before this paper was done by Jen Lynch, who's in the upper right corner, looking at how cerebral oxygen saturations change from birth to surgery as the child waits in the CICU. And what we found was that oxygen extraction here in the upper right panel of this figure continued to increase on a daily basis, but that increase was not met by cerebral blood flow changes in the same direction. So there was no increased delivery to accommodate the increased consumption. And so this is an explanation for something that we saw back in 2009 with Chris Pettit. So using quantitative optical tools, you can now hone in on a lot of the physiology and measure things around interventions or just routine care. In our babies, cerebral blood flow does not compensate. Changes in cerebral blood flow cannot compensate for increasing oxygen extraction. So what are our modifiable factors here? Well, surgery is semi-emergent and has to occur before 5 days of life if your goal is preventing brain injury. Maximizing oxygen content may also be very important. And there's a possibility of manipulating cerebral blood flow, at least for the short term, by increased inhaled carbon dioxide. But now we need to talk about some advanced thinking too. And the next two slides are actually from my friend Ken Brady's. And this is Marek Pcics-Cnoc-Cha, who is at Cambridge. And he is a deep thinker and has done a lot of studies looking at how to measure cerebral autoregulation. And the figure here is an autoregulation curve, which shows you for a small band of arterial pressures, cerebral blood flow or cerebral perfusion pressure is maintained at a constant level. But if you drop the blood pressure too low, now the cerebral blood flow becomes passive with arterial blood pressure. And conversely, if the blood pressures go too high, cerebral blood flow will also be passive. At the higher blood pressures, of course, there's risk for cerebral hemorrhage. And at the lower blood pressures, there's risk for ischemia. So how do we measure this? Well, this is where my friend Ken Brady comes in. And if you note, he's wearing a sweater that is very similar to the one from this movie back a while back. So autoregulation curve here pictured again. Ken measured arterial blood pressure and cerebral blood flow by Doppler, as well as tissue oxygen concentrations in the brain and total hemoglobin. Relative total hemoglobin was measured with NIRS. And if you look at the relationship of arterial blood flow and cerebral blood flow, he mapped these in a piglet during an exsanguination experiment. So the following blood pressures are due to exsanguination, and he actually was able to map this perfect cerebral autoregulation curve. Now, if you take cerebral blood flow and you look at the relationships between cerebral blood flow and arterial blood pressure and do a Pearson coefficient, correlation coefficient, you get HVX. And you can map HVX as you increase the arterial blood pressure, and you see that that coefficient drops until it becomes negative. And that corresponds to that inflection in the autoregulation curve. So mapping the lower limit of autoregulation can show you where your blood pressure is in the sweet spot of autoregulation or where it's fallen before. And this figure shows that. Here is a continuous timeline of arterial blood pressures, and below it, not on the same x-axis, this is arterial blood pressures now on the x-axis, and that Pearson correlation coefficient on the y-axis, showing you the point where the correlation becomes minimal or no correlation, and that is your lower limit of autoregulation. And you can view this, let's play this, in a three-dimensional plot where you're looking at blood pressure on the x-axis, age of the patient on this other x-axis, and the Pearson correlation coefficient on the y-axis. And you can see that it changes for the age of the patient and the blood pressure. And what you're looking at in the blue is where there's no correlation between blood pressure and cerebral blood flow. And in the red, where the blood pressure is too low. And this is human data. So the lower limit of autoregulation lies somewhere between 25 and 50 millimeters of mercury, but this is highly individualized. So this is a tool that we can use. And why is white matter injury so important in preventing? Well, this is data from 7-year-old subjects, 13 subjects in all, from a cohort of mine, where we brought them back for testing. And I separated things out into depression, attention, theory of mind, and anxiety on abnormal testing. And you see that the abnormal testing occurred in a high number of these patients. And of those patients, 3 out of 4 patients with depression had white matter injury. 5 out of 7 with inattention, clinical inattention, had white matter injury. And if we plot these into this Venn diagram, we see that depression was a major problem in patients with white matter injury. In fact, among the 4 that report patients with depression, 2 reported suicidal thoughts. And these are 7-year-olds. One of the patients that really had abnormal testing in all modalities had the highest volume of white matter injury, so the most severe white matter injury. The other patient did not have a postoperative MRI due to ECMO. And the one real star with a full scale IQ of 136 had crippling inattention and white matter injury in the moderate range. So I think if we tackle white matter injury and prevention of white matter injury, we can improve the long-term cognitive outcomes and functional outcomes in these kids. Because clearly an IQ of 136 does not save this kid from poor school performance and a lower chance of successful adult independence. So this is my 15-year reunion from my lab, and I'll stop talking now. Thank you.
Thank you, Dan. Excellent presentation and very concise in a short period of time. We're all appreciative of your efforts. Our last presentation in this section is by my colleague, Jennifer Fogel. She is currently a speech language pathologist at Advocate Children's Hospital in Oak Lawn with myself. She provides services both in our pediatric cardiac intensive care unit, our high-risk single ventricle clinic, and in the neurodevelopmental follow-up clinic. During her more than 20 years in the field, she has specialized in pediatric feeding disorders. Her career focus has been working with infants born with complex congenital heart disease and their families in the pediatric intensive care unit before and after surgery. She has been actively involved in the nutrition and growth committee initiatives through Pcics-Cnoc-Cha and the co-chair for the Pcics-Cnoc-Cha Education and Training Committee. Jennifer is going to describe biting off what you can chew, promoting feeding skills in neonates with critical congenital heart disease. Welcome, Jennifer.
Hello, everyone. Can you hear me okay?
We can, thank you.
Okay, thanks. So I'm going to try to give an hour presentation in about 10 minutes. So I just want to thank the Congenital Heart Association for having me speak today on feeding. Thank you to Jill and Justin for really pointing out that there's a human being in that bed, and that we can't just focus on numbers all the time, that we have to think about neurodevelopmental outcomes for these patients. Thanks to Sam for really pointing out how to adapt the environment, and our other speakers today. It's been a great lecture so far. So thank you. It's an honor to be speaking today with some of the founders of neurodevelopmental care. I wanted to start with this picture of my team, because listening to all these talks, we can talk about the research, we can talk about what we need to do for patients, but unless you have a great physician champion, it won't work in your unit. And so I want to thank Dr. Van Bergen for really championing neurodevelopmental care in our unit at Advocate Children's Hospital. It's really evolved over the last 10 years. And we have great therapists, dietitians, nurses. So if you are a cardiac intensivist listening today, I encourage you to form your team, to pull your therapists and nursing together, and champion your own neurodevelopmental program. So when we look at what is feeding, it's so multifactorial. It's not just bringing a baby to breast or giving a bottle. It's not just how much volume did they take. Can we get them off the NG tube? Feeding is social emotional for the parents. Feeding is a bonding time that develops into going out to dinner with your friends and family. Feeding starts from day one, not after surgery. We're going to talk about some factors that are involved with oral feeding, and looking at pre and post-op opportunities. It was really great to see some of the answers regarding the questions of when feeding therapy should start. Feeding therapy should start day one, meeting with the parent at the bedside. Also, how Sam talked about family-centered care, and Dr. Sood, how can we get parents more involved versus them sitting in a corner just looking at their baby and watching nursing take care of their baby, and how the medical team can collaborate. It's so important. It can't just be the feeding therapist's job to develop a plan of care for feeding. We really need the buy-in of the medical team, the respiratory therapists, the nurses, the physicians. And when we talk about feeding, we think of experience versus volume driven, and then aspiration concerns, always the biggest thing on the table that people want to know. Did they pass or fail their swallow study? And long-term neurodevelopmental outcomes that impact feeding for a lifetime. So hemodynamic stability preoperatively, I am usually called the first day the baby's born, once the baby's stabilized, umbilical lines are placed. I'm there to work with nursing on, and our lactation nurse on breastfeeding and skin to skin right away. In fact, at our institute, we've implemented prenatal lactation support. After a mother receives a diagnosis, they are provided with literature and classes for pumping. Our institute went from 40% of mothers pumping breast milk to over 90% for the last 2 years. This was an area where mothers felt empowered that they could contribute to their baby's healing. We need to look at neural protection. When we look at these pictures, we look at how a normal newborn is brought to the mother's chest and the mother speaks to the baby, versus some of our babies are held very briefly and then brought to a noxious stimulation room. Lines are given, there's no swaddling. So we want to be able to teach parents and nursing staff neuroprotective efforts to help protect that brain. We want to look at parent involvement. Even if our babies are intubated, we can provide milk swabs, and not just taking a swab and swishing it through their mouth, really taking that swab and helping with lingual exercises while the intubation tube is there, working on sucking. If the baby can accept oral feedings, then we offer those as well. And then we look at hemodynamic stability postoperatively, and this really drives what our interventions are, but no baby is too sick for interventions to begin. If they're intubated, look at their ventilation. What sort of equipment do they have? Can mom be holding or dad be holding? Can we do some skin to skin? So taking all those things into consideration, feeding doesn't just start when food goes in the belly. And I appreciate Justin shared this picture earlier, family-centered care. What does that look like when we have all this equipment and all these alarms and people are rounding and coming in and out? We often do see that parents sitting at the side, staring, looking at their little baby. Something nice to do is say, congratulations on your baby. I know this is a tough time. Encouraging the parent to hold the baby's hand, hold their head, help participate however they can. And even giving them a book to read. It's so important for the baby to hear their parent's voice. That's good for cognition and communication development, but that also is a ground for feeding development because it becomes more social emotional as well. As Sam and Amy Lasanti and we contributed to this individual feeding plan. And a colleague of mine reminded me that feeding is driven by an individual plan and it needs to be unique. And the person that drives that feeding is the patient themselves, not the speech therapist, not the parent, the baby. The baby drives the feeding and the baby lets us know when they're ready for feeding and when they're ready to take more. So always remember to make your plan individualized, not based on cookie cutter plans. I really like this picture. I know it's sort of an older picture, but I still see this position sometimes when I go into the room and the nurse is providing the feeding. Jill, I loved your presentation on good nursing care, and we continue to provide education, but often the baby is being fed in the bed, they're not swaddled, they're not provided the flexion and containment that they need to focus on feeding. I'll often ask nurses, so tell me how you learned how to feed a complex medical baby. And the reply is always, I didn't. So the feeding therapist isn't there to own the feeding or take away the feeding. We're there to help support the needs that the baby needs to have successful feedings. So it's really important that the medical team embraces the plan and can support the team in looking at ways to provide neurodevelopmental opportunities for feeding. When we look at experiences versus volume, again, it's not about how much did the baby take PO today. I hear that often during rounds. Is the baby taking full PO? Can we send them home without an NG tube? We need to teach our parents and teach our medical staff that feeding is about experiences. So looking at feeding readiness, all babies will root and suck. They have these reflexes. It doesn't mean we're ready to feed. We have to be awake and alert. We have to be quiet alert. We have to show readiness. Bringing the baby to breast. This is so important to so many moms. Just because they've had surgery and they may have weakness, it doesn't mean we can't provide this opportunity. And finding a great lactation nurse to help support this is wonderful, or taking a class in lactation so that you have more knowledge about how to help parents is important. Our unit, Dr. Van Bergen helps support buying pumps for our unit. Our mothers get meals, and we always make sure they have a full bottle of water to make sure their milk production is good. Holding during enteral feedings is very important. Instead of just letting the baby lie in bed and get their NG feeding, it's so important for them to get that proprioceptive input. Hearing their mother or father's voice, feeling their body is so important. Tastes of milk to the lips, just like the picture with the little baby. We'll put milk on the hand and bring the milk to the lips to give taste, texture, and elicit some sucking is nice when they may be on too much respiratory support. We provide soft stimulation to the cheeks and the lips. These are nice, again, experiences for the baby versus shoving a bottle in the baby's mouth to see if they can feed. Studies have shown that babies that receive gentle and consistent oral stimulation get to full bottle or oral feedings sooner than those that don't. We want to provide educations to our parents. From day one, I will meet with a parent and talk to them about the feeding journey. We want parents to know that this is a normal journey, that most babies do need feeding support, and that it's okay. It can be typical. I think there's a lot of pressure to parents when we tell them, oh, we'll work on feeding and we'll get rid of that too. They need to understand that this can be typical. And I loved Carly Nagrin's poster from Nemours this year at Pcics-Cnoc-Cha. She talks a lot about the first feeding, not robbing that first feeding opportunity from a parent. And I've had a lot of good experience calling the parents to the bedside. You'll often hear the nurse say, well, they never are at the bedside, they don't come. But parents really do want to be involved. And so if possible, if we can provide that opportunity for the parents to give the first feeding, and then I'll put the date on the bottle so it's a keepsake. Aspiration, the big scary word we always think about. And as feeding therapists, sometimes we can be the grim reaper and say, oh, they can't have anything by mouth. I hope that we've evolved quite a bit, especially with this special population, looking at more opportunities, working with babies that are on high flow. A lot of the research is based on prematurity. These babies are have different circulation and have different respiratory needs. So working with our respiratory therapists and our physicians on opportunities. Looking at sedation and state regulation can certainly impact aspiration risks. And base of tongue retraction is actually the #1 cause of aspiration. So some of our babies are born with low muscle tone, decreased strength. So something to keep in mind, maybe a baby latches onto a pacifier, but it doesn't mean that they have great oral motor strength for drawing the liquid and carrying that bolus safely back into the pharynx. Vocal cord paresis, we see that with some of our heart defects. Definitely a concern, but doesn't mean that we have to prevent feeding just based on vocal cord paresis. We can do different positions to help with small amounts. And then looking at suck, swallow, breathe coordination is always important. Again, when I see the nurse holding the baby in the previous picture and the baby is trying to breathe and suck and swallow, and the nurse is like, oh, they're doing great, but they're really not. We need to do special safeguards in order to prevent oral aversion. These are some of the diagnostic tools that we use to confirm aspiration, but we use these tools to look at the physiology of the swallow. What can we do to adopt the bolus control for the baby to prevent aspiration? So a video fluoroscopic study in radiology, a FEES, but we don't need these things before we try feeding a baby. And I loved the response about, do they need a swallow study before feeding? That's the old way of thinking. Babies and children need to get their feet wet. They need to experience feeding before they can jump in the pool and swim. So we don't want to bring an infant down for a diagnostic test that hasn't had any experience. We're going to set them up for failure. Aspiration can occur anytime, and we know that infants with congenital heart are at a higher risk for aspiration, but we can make some modifications in order to prevent aspiration and still give nice neurodevelopmental experiences for feeding. We can use the slowest flow nipple. Dr. Brown makes an ultra preemie nipple that I like to use postoperatively. It controls the bolus size. It's not about the slowness of the nipple, it's the bolus size, and so I educate nurses and parents on that. We need to look at positioning. Side lying is best for breathing. It improves airway and also with flexion and stability for the baby. So they're not worrying about where their arms and legs are when they're trying to feed. They feel comfortable. External pacing, that is where we tip the bottle down in order to give the baby a more deeper breath in between feeding. And then lateral hold of the bottle instead of upward. I often see pictures on Google and I see parents holding their baby in prone and holding the bottle upward. That gravity is going to increase the flow of that nipple. We can limit the volume. We can do 5 mLs twice a day. We could do 10-minute feedings in order to let the baby increase their strength and endurance. So just like we learned, they don't get the best oxygenation to their muscles. This is going to impact their strength. Long-term neurodevelopmental outcomes for feeding are so important so that that baby can eat that birthday cake at their first birthday. It's definitely a team approach. It's not just the feeding therapist anymore deciding whether a baby feeds or not. It's working with the parents. Feeding is more than nutrition. It's going to develop into an activity of daily living, and we want to set families and children up for success. Most importantly, when your patient is getting ready for discharge home, it's really important to have a tube weaning plan so that parents don't feel that they go home with supplemental NG feedings and no support. Our parents, through some of our collaboratives, have definitely expressed that they want support. They want a plan, not just going home with an NG tube and no support. As Sam mentioned, we have a cardiac neuroborn neuroprotective network. This is a Google group that we started a couple of years ago. Sam and I had met at several conferences, and we said, you know, yes, we've talked about infant care, but that's where development starts, is day one. So this is a group of professionals where we support each other with thoughts and ideas. We have some projects, and I want to congratulate Courtney Jones and Hima Desai, who just recently submitted publications for disruption in feeding for infants with congenital heart and cardiology in the young. So be looking for that. That will review a lot of what I spoke about today. And we're working on another paper to look at interventions. If you'd like to join the Google listserv, there's my email. We also became a special interest group with CNOC, so that's really exciting. We're gonna be working on some more projects to focus on newborn care. And follow us on Twitter at Newborn Cardiac. Thank you.
Jennifer, that was a fantastic presentation to wrap up that kind of specialty section. Thank you for all that really practical information. Our final formal presentation will be from Melissa Jones. She is a nurse practitioner and director of the Neurocardiac Critical Care Program in the Cardiac ICU at Children's National in Washington. And as the director of that program, she leads an integrated multidisciplinary team focused on eliminating secondary brain injury, optimizing brain development, and promoting healthy family bonding in the cardiac ICU. Finally, Melissa is the incoming president of Pcics and a member at large of the Cardiac Neurodevelopmental Outcomes Collaborative. And she is going to talk to us about something very important because without team building, authentic leadership, and solid buy-in, everything that we just talked about kind of doesn't matter as much. So with that, I'm very excited to hear my friend Melissa Jones wrap up our presentations before our panel discussion.
Okay. Can you guys see my slides okay?
We can see it. You are in presenter view, if you might want to change that.
Okay, let's see. I had a feeling this would happen. Let me X out again. Is that still presenter view?
It is.
It is, okay.
But if you go from start from,
let's try this one. I practiced this and it worked, and now it's changed. Is that still presenter view?
It is.
I think that was it, Melissa, where it says swap preventer view and slideshow.
Okay. Here.
It was up at the top, Melissa.
Up here.
The display settings.
Okay.
There you go.
Okay. The only
You're good.
thing is I don't see my notes. So hold on one second. I'm sorry about this, guys. I know we're on a tight timeline. Is that still presenter view?
Yeah, we can see your notes.
You can see the notes. Okay.
Melissa, let me suggest one other thing. Go into your slideshow view, or the regular, when you just open up PowerPoint.
Okay.
And
Sure.
in the bottom right, next to the volume slider is that
Here.
one. Yeah, see if that works. Probably doesn't, but sorry.
No, you can still see the notes. Let's see. I'm really sorry. Hang on one second. Let's see. did work. I'm just going to stop the share.
Hit play from the beginning.
Let me see if I do from beginning here. And then I do share. How's that? Can you guys see the notes?
Yep.
Okay. Well, perhaps I'll just I'm really sorry. Let's see.
Melissa, if you need your notes, go for it. We're more interested in listening to you anyway. We're not going to read ahead. Whatever you're comfortable with.
Okay. Okay. Let's see if I do.
So we're getting some comments in the chat box. That's surprising. One of them says, go to display setting and set it from dual.
And what?
And shift it to dual.
Okay. Here.
Your display settings were at the top when you shared your screen. When you had when it was actually running from current slide.
Okay. Okay, maybe I can.
That looks good.
Okay. I just don't have my notes, but maybe.
You're a rock star, Melissa. You know this stuff.
Okay. I'm just going to try and do this. Okay. I'll just go without notes. So bear with me. I am really happy to be here, and I feel like very grateful to all of the organizers of this, particularly Gil and Sasha and Grace for organizing the whole Congenital Heart Academy, providing these amazing free webinars, and then to Justin for setting up this collaboration between PCICS and Cnoc. I think that the format of this has really led nicely into this talk, which I've changed the name a bit to Herding the Experts, Team Building, Authentic Leadership, and Creating Buy-in. I have no disclosures except to say that I'm not an expert in leadership or teams, but I find this work very interesting and very relevant to providing high quality patient care. So today we'll highlight some of the concepts of team science. We'll apply team science to building an ICU-based neurodevelopmental team, and we'll present leadership styles that build trust, promote individual growth in high-performing teams. So as mentioned today, you can see that all of these particular individuals and groups contribute to the long-term neurodevelopmental outcome of our patients. So this paper titled The Secrets of Great Teamwork is from the Harvard Business Review. The piece of art on the left is an art or a painting that is at the Museum of Fine Arts, and it was placed into as the title of this article. And I think it really nicely represents both the beauty and the mess of our hospital-based teams. The authors of this article, Haas and Mortensen, I don't have my notes, so I'm just trying to remember, present these 4 Ds of current teams: dynamic, diverse, digital, and dispersed. Interestingly, this article was written in 2016, and I think that we are now some of the things are even more relevant now than they were then. Before we get too far into the teamwork, I do want to just make a distinction between the team science that I will discuss here and the team science that we often hear in healthcare, which is more related to ad hoc teams. I will be talking about stable teams. Ad hoc teams are teams that get together in the setting of resuscitation or ECMO deployments, but this talk will be centered more on stable teams. So Hackman was a researcher and one of the leading organizational behavior scientists in the 1970s, and he really defined some of the conditions that enable strong teamwork. What he found was interesting was that individual behaviors, personalities, and attitudes really don't contribute very much to the success or failure of teams. But what creates positive teams are these three conditions: compelling direction, a strong structure, a supportive context. And then recently, the authors of the Harvard Business Review article, Mortensen and Haas, suggest that there's a fourth condition that would address more of the modern day sort of challenges of teams. So a compelling direction is something that energizes, motivates, and engages our team. It's defining why we are all here and what we're doing, what our goals are. So a compelling direction, when I think about it as it relates to our neurodevelopmental teams in the ICU, it really should compel each of us to think individually of where do I find meaning and why do I do this job? And I would suggest that most people who come to the ICU, most people who work in the ICU, would say that they are there because they want to see children thrive with their families outside of the ICU. And we all get there in different ways. But I think that when we are able to define this goal and really articulate what drives us, what motivates us to work every day, that really can help to gel our team and center us around a sort of mission or a vision. And as Gil mentioned earlier, the mission that we came up with for our neurocardiac critical care team is to eliminate secondary brain injury and to promote neurogenesis in the CICU. So how we did that, what we found is that we as a team, the neurocardiac critical care team, which was again represented in that earlier slide, all had this sort of same goal, and we were able to articulate why we were there. Our next goal was to really engage our bedside staff, the whole team in the ICU, to understand the importance of their microscopic decisions each day and how they are impact the sort of prognosis, or if we look through the telescope to see where these children end up, that each of us has a ability to impact those long-term outcomes by all of the tiny decisions that we make shift to shift and day to day and hour to hour and minute to minute. And those have all been discussed today, all around feeding, sedation management, how we respond to blood gases, how we position babies, how we image babies. So all of these things have real impact on the long-term neurodevelopmental outcome. So the way we executed this in our program was that we blanketed our staff with education. So we went to all of the standing education forums. We embedded neurodevelopmental care in our orientation and all of the ongoing education in the unit. And then I think maybe as importantly, maybe even more importantly, is our informal education, just-in-time teaching at the bedside, our informal role modeling. So in this picture is Erin Griss, our child life specialist, who is absolutely amazing. And she, I think, is just a real leader in our unit, because what she does bedside to bedside is she role models developmental care and normalizes holding babies, making eye contact with babies, and role models it both for the staff at the bedside, but also as a way to engage parents. So the second enabling condition is providing a strong structure, which I think about as welcoming a diversity of ideas and backgrounds. Our teams look a lot different, and certainly, as you can tell, even just by the representation on this webinar, that a diversity of ideas and backgrounds and thoughts and experiences will only make our group and our team rich with new ideas and innovative thoughts. It's important to determine the right size of the team. We want to have a diversity of ideas, including everyone can inhibit both productivity and it can inhibit communication. It can cause fragmentation of the group. Establishing norms and expectations is critically important to the team, both to establish accountability, and then managing conflict. So what we don't want to do is suppress ideas or avoid conflict, but rather engage in dialogue so that we can generate new ideas and innovative new practices. So in their new book, Frances Frey and Ann Morris, called Unleashed, they talk about these 4 stages of inclusion. And the first is that people need to feel safe and then welcomed, and only once those things are established can they be celebrated and cherished. And I think in our neurodevelopmental program, we worked really hard to establish a safe space and make sure that new ideas were welcomed, and that regardless of somebody's training or expertise or experience, that we really wanted to create a diverse set of thought or a diverse set of ideas. What I realized is that it was a humbling experience when I got our team together several years ago to start our neurodevelopmental rounds. I thought I knew CICU jargon, but as it turns out, the therapists had a whole new set of jargon. And I thought, geez, I don't know anything about this stuff. And they really helped to elevate all of our knowledge around developmental care. And the other thing I realized is that when I talk about wanting to create a welcome environment and then celebrate successes, is that I didn't know anything about the therapy, how the therapist reported, their reporting structure, their sort of clinical ladder, or even their previous training. I wasn't sure what their commitment was to the CICU or what other units they needed to cover. And so what I ended up doing is just having individual meetings with them to just better understand what motivated them and what their barriers were to providing the care that they really wanted to provide. So Amy Edmondson is an incredible scholar from Harvard, and she studies teams. Her most recent focus is on teaming, which is more related to ad hoc teams. But this graph really helps us to understand the term psychological safety. I've included on the bottom here her 3-minute description of this, which will be better than mine, but I'll give it a shot. And also the TED Talk where she talks about teams. So psychological safety is on the y-axis and accountability, let's say, is on the x-axis. When there's low accountability and low psychological safety, really there's apathy and no productivity. When there's high psychological safety, but really no accountability, it's a comfort zone. And again, it's safe, but there's not a lot of accountability or productivity that comes from that zone. When we go to the most worrisome sort of zone here is on the bottom right, when there is high accountability, there's a lot of performance pressure, but the psychological safety is low, the psychological safety is low. And so people are not given permission to speak up, generate ideas, ask questions, raise concerns. And what we really want to get to is this learning zone where people are motivated, they have accountability, and there is psychological safety to support all of their efforts. What I think is interesting about Amy Edmondson's talk and her work is really clarifying what psychological safety is not. So psychological safety is not an excuse, or it's not really an effort to be nice to everybody. It really promotes candor, and it is something that I think is an important distinction, because really psychological safety is meant to create an open space for open dialogue, and not something where we avoid conflict or we avoid avoid conflict or expect sort of excessive praise. So along those lines, in Brené Brown's book, Dare to Lead, she talks about this concept of rumbling with vulnerability and recognizing where we are and having the ability to share our own vulnerabilities and what we need to learn and where we need to go in a way that builds trust within teams. And similar to Amy Edmondson's work, and one thing that I remember that I sort of say a lot to myself is that clear is kind, and that while I oftentimes might have trouble with addressing an issue, or I probably tend to be on the more conflict averse side, I would say that this is a really important message, that clear is kind. And when we work within teams, holding each other accountable will only foster more trust and productivity and performance within the team. The third enabling condition that we'll talk about is a supportive context. So really the way I think of this is the scaffolding and the tools that allow the experts to work. So it ensures efficient processes, and by that I mean that when we have meetings, we are respectful of people's times, and so we start and we run effective or efficient meetings. Providing access to data and education. So we want to feed this and nurture this sort of sense of curiosity and enthusiasm by providing education. Providing data to staff, like short bits of data, can really help to sustain the program. So I always think of a nurse who may come to me and say, you asked us to change our practice around X. What has that shown? So providing sort of routine, small bits of feedback around either compliance or outcome data, I think can be a very effective way to sustain a program. And then I think that I would suggest that an effective leader also reinforces and celebrates good performances. So something as simple as a complex patient who, let's say, had chronic critical illness for had a long stay in the ICU, and it took a lot of expertise and coordination to get that patient home, I think that's something to certainly celebrate. So a supportive context, I would say, is scaffolding and tools and maybe even some cake. In his book called Give and Take, which I think is a really great read, Adam Grant talks a lot about these three sort of categories of people. There's takers who are always looking to get something. There's matchers who are looking to keep an even, who are looking to always give and take. So they want to have an even match of they're going to give you something, but they expect something back. And then there's givers who are always willing to give without any expectation that they will receive anything in return. And what he found is that with the caveat of that givers tend to burn out sooner, so we should probably work on that. But givers are in across a variety of industries have been shown to be more successful than takers or matchers. And so this book, I think, gives us permission, and it also gives us encouragement to give, to continuously try to support our teams and our colleagues, both to meet their individual and our team goals. So in practice, this means respecting time, making data accessible, nurturing curiosity, providing feedback to staff, pausing to recognize our wins. And then finally, shared mindset was the fourth condition that was added, again, to respond to sort of this new face of teams, which, you know, diversity and distance in digital communication has a lot of upsides when it comes to teams, but it can also foster this sense of us versus them, or a sense of incomplete communication or incomplete information. The researchers in this article talk about this concept of how when things are complicated, we will develop these cognitive shortcuts, and they help to simplify complicated situations. So then we draw conclusions about teams, and we tend to look more favorably on our own group within the team. So it's important to address these issues. And one way to do this is to really create a shared identity and always sort of refocus on that shared identity. So when we go back to our shared mindset, this team is, here we go, okay. This is the full team, and this team is key in getting our patients to our shared goal, which is to have them thriving outside of the ICU setting. So a successful ICU neurodevelopmental team is a well-coordinated, collaborative effort, promotes a diversity of background and ideas, it elevates expertise and disseminates knowledge, fosters curiosity, and keeps our patients and family in the center of everything that we do. Because we aren't working to just get children discharged from the ICU, but we're working to really create these bright futures. So thank you for bearing with me and my no notes. And thank you to our entire neurocardiac critical care team. This brings a lot of joy to me personally and professionally. I feel very privileged to be part of the group here today. And I just want to say a special thank you to Lily and Sue for her contributions to this presentation. Thank you.
Great. Thank you very much for that excellent presentation, and obviously impromptu presentation. Sorry about the technical difficulties that you had. You did marvelously, though. We are going to unfortunately skip over the polls, it looks like, and go right to a panel discussion so that we can have some collective answers from this really, really impressive panel in front of you today. We have some additions in addition to the speakers that have already spoken. And so we are just going to do a quick introduction of the newcomers that did not speak earlier, so you know who they are, and then we will open it up for some ongoing discussion. So start off with, I'd like to introduce David Winlaw, who comes to us as a surgeon and researcher at Cincinnati Children's Hospital Medical Center, having recently traveled here from Sydney, Australia. Also, Dr. Uri Polak, who is the section head of critical care at Hadassah University Medical Center in Jerusalem. And Dr. Latal, who is the co-director of the Child Developmental Center at the University Children's Hospital at Zurich. Welcome.
Final two additions are Paul Kekia, should be here. I don't see him right now. There he is. There you are. Who needs no introduction. He would just like to be Gil when he grows up. And then Kathy Masato. Dr. Masato is an outstanding nurse scientist who played a revolutionary role in the evolution of cardiac developmental care, who is currently an associate professor at the School of Nursing at the Milwaukee School of Engineering. So thank you for everyone. There were a lot of questions in the chat box that everyone can chime in. I'm going to start off though, since this is a multidisciplinary panel, and this is really directed to Justin and Andrew and any of the other physicians. So Justin, you really talked about moving efficiently through the ICU and incorporating strong pediatric critical care concepts to decrease complications and get our kids out. And then Jill talked about the importance of nursing and bedside. But what are some effective strategies that physicians have employed to really set a tone of importance that developmental care is really important in the cardiac ICU, and have the whole team follow along, making for it, supporting some of those nursing interventions, right? We say, hold a baby. Well, maybe nurses can't have babies out of bed without strong physician support. So that's the conversation that I was interested kind of in starting off the bat.
Yeah, I think that's fascinating, and probably what led to a lot of our efforts starting here. You know, I know Jill and I have been working together, but really it's been a big team member. And I think, as I kind of was alluding to in my talk, and as Melissa also said, it's not my area of expertise necessarily. I'm not a developmental expert. I'm not a mental health professional or anything like that. And so I think it was really kind of maintaining that perspective that we actually care, you know, how these kids do in the long run, and that it actually is important, and having a little bit of realization, I think, that we do set the culture a lot of times, for better or worse, as the people who are the intensivist in our ICU, and trying to have that humility to go to your multidisciplinary team and really get those people together. So get somebody like Jill on board. We have Robin Schlosser and Kelly Davis and our nursing experts and everybody here that we have at Texas Children's, and we kind of just put a team together. And then one of the things that I struggled with, and I'd be curious how Melissa, you know, I think she and probably others have gone through this as well, was once you do get everybody kind of in the room, everybody's excited about this and kind of ready to have a voice and stuff, and it can be challenging. So we started a little bit, we tried to start in a systematic way so that it wasn't overwhelming. And so we started with developmental care rounds and this developmental care workshop that Jill talked about, to really try and increase awareness, education for the bedside staff, and have tried to empower them to speak up a little bit during rounds and make sure that they know that their voice is key, and that they shouldn't be hesitating to talk about things that we want to hold our patients. And we've seen a pretty big increase, I think, Jill, in kind of a lot of these measures. What do you think?
All right. Yeah, I do think that we've definitely come a long way. I know from when I first started and when the developmental care team first started at Texas Children's, we would be on rounds and a baby would be laying and crying in the infant pod. And I would just look at the baby. I'm like, why aren't you picking that baby up? And the response was always, well, they have an art line. So from that thought to now we frequently hold intubated patients. I think that the awareness and the, I guess, ability has increased a lot. We have a long way to go, but we have definitely come a long way. I think a lot in part due to your work and leading our team.
I think it is helpful for the intensivist too. I mean, some of these things are hard to quantify. So I'm curious, I know that I'm not sure if Karen is still on, but it's nice to bring back to your other team members who maybe this isn't their passion project, you know, for me to convince Paul why this is important. So I'm curious what other team members are doing to quantify what we're doing that's developmentally supportive, because that's always a challenge for our team, I think.
I think we did a survey, this is Karen, we did a survey after we had implemented developmental care rounds of the nursing staff and asked them whether over that time they had increased their knowledge or it changed their practice. And while the majority said that we'd reinforce their knowledge, so somewhere back there they kind of knew that all the things that we life better for these babies were good things to do. But they really, really endorsed that they had changed their practice. It was just increasing their awareness. And I think they're empowering them to know that they could make a difference in something that was really, really important to the long-term outcome for these babies. And so we did that to try and evaluate the outcome. And then, you know, our most recent research study is specifically looking at what doing the tummy time, prone positioning, how that has affected their motor development at 3 months after discharge, and are finding encouraging results. So, but it is hard to measure.
At Advocate, I always am concerned with the increasing number of attendings. That there can be a difference in techniques and strengths and priorities. And so I put together a rounding tool, and included in that rounding tool that they have to complete daily is a section on developmental care plan. And so to try to create not a universal, but that everybody's addressing it on a daily basis, the nurses have to report what the developmental care plan is and what they're going to do and what their plans are for that day. That's in addition, obviously, to the developmental team coming in on a daily basis. But I have the expectation that all these infants are held at least twice a day, 8 times a day if they're feeding, and that they have tummy time or prone positioning time at least twice a day in almost all states. So I think by having checklists, which I'm not a huge fan of, it provides some sort of accommodation that all of the attendings hopefully are going to be carrying on that same philosophy and that same plan. You know, one of the really leaders in the infancy of this neurodevelopmental outcomes collaborative is Kathy Mosato. I was wondering if you have any opinions on bringing this to the bedside, how you did it successfully at Milwaukee.
Thank you, everyone. It's been such a pleasure to be a part of this, and I apologize. I'm a teacher now, and I have to teach a class in a few minutes. It was a process, just like many of you have echoed. It didn't happen overnight, even though people inherently knew that it was the right thing to do. It took time, and it evolved over time. We started with our outpatient developmental follow-up clinic years before we ever brought developmental care to the bedside in the inpatient setting. My opinion has always been start somewhere, do something, and you're making progress. I've been a part of Pcics-Cnoc-Cha since its inception, and none of the programs represented had the whole package right off the bat. So far better to start somewhere. One thing we've struggled with that I would love to hear people's opinion on is who pays for developmentally supportive care. Making developmental care rounds is not a service that we bill for. It's been hard to get the therapists the dedicated time to participate. I would just like to toss that out to the group and ask how people have managed that issue. Thank you. It was a pleasure to see all of you.
Thank you, Kathy. That's an incredibly loaded question. Does anyone have any specific earth-shattering response? Mine is look at the return on investment. And so it's a program that we offer because we are going to have improved outcomes later, which is going to be a money saver in all aspects. But I don't know if anybody else has some great information on that.
I would add one thing, Andrew, and because, you know, the bottom line is money is always the answer. You just have to ask the right question. And fortunately, U.S. News and World Report has put this as part of what they consider an excellent program. So that drives a lot of this. I think we also have to remember, I'm glad Ori is on from Israel, that what we have to deal with in the U.S. may be very different in other places. But I think that's a fantastic question, Kathy, you know, and it's because it's not fee-for-service bill bill per event, but it's part of my role as the physical therapist in the CICU. But this is clearly a challenge in every unit, I would think. Do you have a similar challenge in Uri in Jerusalem? What are you doing there, and what's the care like there? Sorry to jump in with the moderators, but I was very curious how this looks. And David might be able to share his view since he just came from Sydney.
First of all, thank you for inviting me to participate in this distinguished panel. Well, actually here in Israel, we have a different health system. The billing system is totally different. We're not paying directly to the hospital. We're paying to one of several different public health systems. Everything here is public, nothing is private. And actually, even though we can't compare it, let's say, to Texas Children's or to Washington, I think that the patient care here is decent, and we can provide most of the things that the panelists have talked about during the talks. One thing that I really wanted to ask, to find out how it works in other places, we know that the NICU team is great in changing the environment, in normalizing the environment, and trying to minimize the, let's say, iatrogenic sequela of the things that the patients have undergone during the admission. If it's the cardiopulmonary bypass or the surgery or the ventilation or the anesthesia. And what I wanted to ask after we finish answering Gil's question, what I wanted to ask is, how do you communicate with the NICU team? How do you collaborate with the NICU team that they are doing, to my opinion, at least in the hospitals and the health systems that I worked in, much better than I do, and much better than my team in taking care of the preemies and the neonates with regards to normalizing the environment, both the inner environment and the outer environment.
Great question. Thank you very much. There's a couple specialists I think they're here that probably could answer that, or at least help. Jennifer Fogel is rounds in both of the NICU as well as the PCICU, and you know, I'm not sure if Paul has any comments if they have neonatal consultations in their unit. If either of you want to field that question.
Jennifer, go ahead. I can just comment that a lot of what we've adapted with our newborns with CHD has come from the premature model, and maybe Dr. Butler can talk about that a little bit more too with the NIDCAP model. But yes, definitely that's where we've gained a lot of our interventions and how we assess, but I think we need to also move forward and look at more specific interventions and diagnostic tools for these specialized infants.
Yeah, so we actually, go ahead.
I wonder if I might just join in by making some comments about getting these programs into everyday care. The more checklists that we develop, the more protocols that are invented, and the more we push the responsibility to nursing staff and allied health, the less it gets recognized as being a really important thing. And I think if we can get the majority of bedside cardiologists to embrace the cause, then I think that's, I mean, Gil's an exception here, and of course there are other cardiologists involved, but when the cardiologists see it as a really important thing, it's likely to happen in a more systematic way. But once we do get it going, and I have some experience with this in Sydney, one of our biggest challenges is rolling out to parents beyond the middle class socioeconomic strata. So the group of people who can afford to bring their baby back for assessments and who are deeply invested in their long-term educational outcomes, their children are probably going to do reasonably well in any case, and we can do better with them. But we really have to reach through and pull up the rest of them that are not attending on a regular basis, and especially if it costs them. And in Sydney, the program was starting to send the assessment teams out into their homes as a way of trying to get this done both in the metropolitan area, but also in the regional areas. And most of this is driven by research, but to make it routine clinical care, we have to factor in all these issues.
I would agree with that, and also ensuring that they're, at least on an outpatient basis, that their outpatient developmental care is coordinated around their medical care whenever possible, so that if a family can't come, twice, or they aren't able to take 2 days off from work, that they can get the developmental care that they need during that same visit, and that we're not expecting families to always work around our very rigid schedules, because then families aren't going to prioritize that developmental care appointment. They're going to prioritize the cardiology visit. So I think that's something that we can do.
David, it's Gil. Thanks, Erica. I wanted to respond to what you said about sort of buy-in and the staff people at the bedside, and I completely agree that everybody's got to take ownership. But I don't know what the rest of the viewers as well as the panelists think, but in many units that I visited, if you don't have buy-in from the surgeons, it's much harder to get buy-in from everybody else. I don't want to just pick out one group, but specifically if they don't have to necessarily, I don't expect you, David, to come in and hold the baby twice a day, although that would be great. But if the surgeon says this is an important priority, it's likely to go, at least in the centers I've visited, much more smoothly than if not.
I think you're right, Gil, and it's perhaps an issue more of communication, because we think about it very deeply and we care about it in the management of the circulation and protection of the brain and all those kind of things that, lots of the research has come from surgeons who are worried about those impacts. But yeah, I agree with you. We have to impress upon everybody else that this is something that needs to be done.
And if I can, I think picking up on that, it's really making things a priority and realizing that, one of my favorite things to bring up is that nothing is free in an ICU. And, what you talked about when it comes to everything from a blood draw and dropping the hemoglobin to a little extra sedation, nothing is free. And I think once we see that as the priority, then every one of us buys into that, because it's too easy to fall into the trap to say, well, we'll give them a little dose of sedation. We'll give them one more blood gas. That's all we need. The blood pressure could be just a little bit better, but all of those have cost. And then it ties into the financial thing that somebody raised earlier, which is financially, also nothing is free. In other words, a little extra sedation leads to a longer length of stay, which can also impact the bottom line and making people see that as a priority as the way to completely shift this dynamic, and then everybody owns it.
Thank you. One of the themes that had been in some of the initial talks was the mental health of the parents, let alone the future mental health of the children. And that's been a very big topic within the CNOC community, as well as within all the other communities when we add another element of health disparities into that. And I'd like to see what other centers are doing actively within the ICUs to try to break down those barriers and address the mental health issues with the parents, address the health disparities, and try to actually, again, prevent secondary harm, which was the goal that we had. Erica, you're probably the strongest advocate and expert in this if you want to lead that off, and then I'd like to hear other people's comments on this matter.
Absolutely. I mean, I think that there's obviously a wide variety of different things that centers can do. At our center at Nemours, we have full-time psychologist as well as a psychology fellow who spend time in the CICU as well as a step-down unit. And so in addition to our social work team, in addition to other psychosocial supports, and I think having dedicated mental health staff or psychosocial staff who can work with parents is really important. Obviously there's other techniques, right? I mean, psychosocial screening, and even just remembering that everybody can check in on how the parents are doing, right? Not necessarily providing formal mental health support, but making sure that parents know that it is normal to struggle with this, and that they don't have to hold it all together all of the time, and that, people really do care about how they're doing. But certainly there's others on the call who can talk about this as well. And I know Sam Butler, you've done some work around this as well.
Yeah, I wanted to add one thing. Just during the pandemic, we have included using virtual visits more often with families that can't always be at the bedside for one reason or another. And I know it's not ideal to do this virtually, but it has brought more families to medical rounds, to developmental rounds, more members of the family too. So it's not just having the mother at developmental rounds. We can also get the father or the grandmother to virtually come to these meetings too. And I think that's been really supportive. It also has led to more time and support for families that can be done virtually with the social worker or the psychologist outside of the time that they're at the bedside when they really just want to be with their infant. Some of the other things that we've tried are having a family support group in the CICU that meets with the social worker and a nurse. And as Erica was saying, the psychosocial screening, I think, is so very important to find those families that might need some extra intervention or support from the very beginning, even prenatally.
I think this is one of the things that's really challenging, especially if you don't have a plan or a program in place. Justin and I have been talking about and working on this, but it's really challenging when we do our developmental care rounds. And one of our questions is, so how are you doing? How are you coping? And more often than not, this is when the mom or dad or both break down and start crying, and they're not doing well. And postpartum depression is prevalent. You add a child with congenital heart disease, then you add a pandemic. And I think one of the things that I really struggle with when this happens is, what do we do? There's, we're attached to and affiliated with a pavilion for women, but they're not technically patients of that. And we don't have a lot of resources to address that at the time. We're working on it, but I guess I don't really know exactly what to do and how to be supportive and helpful and truly address the problem that we've uncovered. If anybody has any recommendations or thoughts about that.
I would honestly say sometimes just asking is an intervention in itself. There are a lot of parents that aren't going to be able to, for a variety of reasons, go see a mental health professional. And sometimes just having the opportunity to to have their feelings be normalized, validated, heard is an intervention in itself. So I think there's often this desire to like, well, I don't want to ask because then I don't know how to solve the problem. But you've already started addressing it by asking. So that's
one of the ways that we found in our program that we've been able to provide some support and screening for parents is through our, well, first we just recently rolled out universal PMAD screening. So we do screen all mothers in the postpartum phase for perinatal mood disorders. And then Jill, to answer your question about that, because we did need to sort of set into place an escalation algorithm in the event that we needed to, you know, address something more emergently. So that was led by our social work team to create that sort of algorithm. But, you know, in practice, I think that the parents, I completely agree with you, Erica, that just sometimes asking the parents how they're doing is like, they can be a little taken off guard because everybody is so focused on the baby. And when you pause after asking that question, I think it really allows for some connections to be made and some support. And then the other thing I would say is that the therapy team really provides a lot of parental role development in our unit, where they really reinforce ways for parents to become involved and to respond to cues that the babies may be giving, or you know, participate in cares, and even, you know, care partnership pyramid that we also use in our unit are providing parents with activities or roles that they can fulfill even when the baby is critically ill, you know, and that can be recording their voice or recording a book on a voice recorder and leaving it at the bedside, or a scent exchange with a t-shirt or a blanket. So I think that as a team, when we have a really cohesive team, we can message to the families different ways that they can stay engaged and fulfill their, you know, need to be parents.
I would agree with that. And I also think that sometimes we think about sort of psychosocial support or mental health support in the traditional way, right? Meeting with a mental health professional. And I think that is what many parents do want, but not all parents. And there's many parents that will say, no, that's not the type of support that I need right now. And everything we've talked about today, all of these aspects of family integrated developmental care is a form of parent support, and does meet that need for many families. And so in a way, that's a way to kind of prevent the more, some of the more serious issues.
Well, in my unit, there's an art therapist, a music therapist that are rounding the parents on daily basis. We have a weekly psychosocial meeting with social workers of the unit, which are at the unit every day with a psychologist. We have a new recruited psychologist right now at the unit. The head nurse and one of the senior attendings should attend these meetings of the psychosocial meetings. And the parents are always part of the morning round. They're participating, they're asking questions, and if it's getting too long, I always go back to them after the round, and they're part of the treating team. And you know, you have to be very sensitive to their needs. If they want to have a bigger part in the team, you may allow it. If they want to take a step back, you should respect their needs and wants. And our social workers do a great job on a daily basis.
This is great discussion. One thing that we really haven't touched on is sort of the cumulative effect of a cardiac intensive care unit admission with a neonate or a young infant or a child and the post-traumatic stress that can happen. And in addition to that, parents see a lot of bad things. And a lot of the patients that we are targeting and our at-risk patients are our longest term patients. These families become friends with other families in the waiting room, or they know when bad things happen in the room next door and that patient isn't there anymore. Or that patient got a heart and they got to go home. Why isn't my baby getting a heart and going home? How can we best think about that and address that when we're trying to support these families? You know, knowing that there is incidence of post-traumatic stress and that this affects long-term maternal bonding and outcomes.
My opinion on that is that, you know, we can't protect parents, unfortunately, from all of those experiences, and we can't protect them from seeing or knowing that bad things are happening to other families' children. But we need to be able to talk with families about it and acknowledge it, and have a conversation. And so not to just say like, oh, we're not going to bring it up because like mom's distressed about this, but to actually say, you know, this is what happened, that, you know, they're friends, and actually go in and proactively say, you know, how are you doing? I know there have been some difficult things going on, without, of course, sharing, you know, PHI, but difficult things going on in the unit. How has that affected you? And provide some education about post-traumatic stress and what those symptoms look like, and how that can, and what parents can do. So I think that's just being proactive, and we can't protect them from everything, unfortunately.
I also think that our care doesn't end in the ICU or the step down. Like, we need to help transition to home. We need to be talking about supports for the family at home. Sometimes, as Erica mentioned, they're not in a place to really start thinking about therapy or supports for themselves when they're in the ICU. But down the road, they might be. And so giving them the resources so they know who to reach out to, who's there to support them, and that they know that it's all right. This is part of the care of your child, is getting care for yourself also, no matter when you decide to do that, either a month down the road or 2 years down the road, whatever it is. That's all part of supporting your child. But we need to give them those resources and that understanding before they ever leave. So I think that's part of our job too, is that preparation from hospital to home includes the support for the family and the child.
I'm always pretty amazed by a lot of our nursing staff who just kind of do this intuitively, and I think it goes under the radar too, who, when there is something bad going on or something that happens in the unit, will very frequently be taking other families aside. And I think acknowledging that and really encouraging it as much as possible, because I think it really can be a lot of the team members who can help with that.
Any other comments on this concept of PTSD and how we can, actually, instead of ignore it and push it under the table, actually bring it up to the forefront? The comments of open discussion, I think, are great. One of the things that I learned through NPC-QIC several years ago is just the simple question, how are you doing today? And sitting down with the family and devoting time to them, not talking about their child, but talking about them, giving them a prescription to go on a date. Most of the parents are young. Getting them out of the hospital, sending them to a restaurant, getting them out around a McDonald's house for a few hours. Their mental health is directly tied to how their child is going to do. And devoting time to them, not talking about their child. Agree. We are opening up more and more questions, and unfortunately not providing all of the answers, which is why this field is its infancy, but a huge area for growth. And it'll be amazing to see what kind of discussions we're going to have if we had the same webinar in 2 years.
We will.
Last 2 years, we have expanded this topic immensely. I can't imagine what will happen in another 2 years. The field is ripe for discovery, for exploration, and for improvement.
I'm going to let Sasha close up as the chair and head honcho and largest Sicilian in charge of the Congenital Heart Academy. And as you all know from The Princess Bride, never argue with a Sicilian when the end of the webinar is on the line. I want to thank the faculty and the attendees and for giving of your time and your information and your expertise. This was a really historic. I mean, it's the first time that PCICS and CNOC have done something collaboratively together. I'm sure it will not be the last time. And it's exactly the way it should be, where long-term follow-up feeds back on the front line. Sasha, would you like to end things up for us? And Andrew and Andrea, thanks so much for moderating too today. It was really terrific to have you as part of it.
Yes, thank you. I want to thank you very much, all of you. I'm sure people learn a lot. You cannot believe how is the power of this type of information that you live on live with a webinar and on a YouTube channel. We receive a lot, and Gil knows how many emails, how many comments, and every single word you use reaching all over the world. It can add something to the clinical practice of people. And again, the Academy, we are learning a lot, and people from Africa, from India, from Australia can reach all this information that probably for you is normal, but most of the people is not able to reach one international conference or will never attend to the World Congress. So the way we start with Gil was like an anti-fragile approach to pandemic disease. And we learn a lot from pandemic also. In Italy, we saw a lot of the reduction drastically of infection in the ICU, because the way the nurse using mask, the mother and the father doesn't reach the child, it reflects a very important reduction in infection. Probably, as Gil say, Italian, Sicilian, we are not very, doesn't wash our hands very well, but we learn a lot, and I'm sure all the people will take again and see again this fantastic. I think that what you are doing, what you are discussing, for you, it's daily approach. For people is completely new sometimes. And avenues from such a unique panelist, it's amazing. So thank you very much. And we wait you in Italy when it's possible, and hoping you will reach here.
It is true. Taormina, where Sasha lives in Sicily, is not necessarily on the usual tourist place for people from the US, but I have to tell you, it's one of the most beautiful places on earth. And when we get done this pandemic, we will be having the Congenital Heart Campus again back in Sicily. And I look forward to those days. And everyone, of course, is invited.